All right. Hi, good morning, everyone. Thank you guys all so much for coming today. My name is Liza. I'm a research coordinator at Dr. Kumar's office, and I'm a member of the HDSA Rocky Mountain Chapter Board. So again, thank you guys so much for making the trip here today to be part of our Family Education Day. This Education Day is hosted by our HDSA Centers of Excellence at the Rocky Mountain Movement Disorder Center and the University of Colorado Movement Disorder Center and the Movement Disorders Foundation. I also want to give a thank you to our generous sponsors today. Over here, we've got Teva Pharmaceuticals, Rare Patient Voices, and Neurocrine Biosciences. So there will be a couple of breaks, and during the lunchtime, we'd love for you to please go visit with our sponsors, thank them for being here, and then, kind of find out what they do for the HD community. So to get started for today, we're going to hear from some of our more familiar faces in our community here in Colorado. To start, we're going to hear from Dr. Emily Forbes. She is a trained movement disorders neurologist at the University of Colorado Anschutz Medical Center. And in combination with Dr. Rajiv Kumar, the founder and director of the Rocky Mountain Movement Disorder Center, they will be speaking about HD research and some promising new therapies. So please welcome up Dr. Emily Forbes.
Today, I'm going to spend some time talking about new promising therapies and updates in research in HD. All right, so an outline of this morning's talk, I'm going to spend a few minutes talking about neurologic music therapy that's being done at the University of Colorado, and then we're going to spend some time talking about gene therapies. Can you hear me okay? Okay. So we're going to start with just a review of what gene therapies are, how they work, and then review trials that are being done with gene therapy in HD. So there's an entire field of study that looks at the effects of music on the brain. There's a CU specialist, Dr. Isabelle Huard, who is studying how neurologic music therapy, including auditory cueing, affects things like fine motor control in people with HD. And so her study is looking at a 15-session neurologic music therapy intervention. So what it entails is there's a first visit where we do some testing. So a lot of that is things that you're used to are things that you're used to, like the UHDRS. We do different surveys and perform a brain scan. And then there are 15 music therapy interventions. And those can be done virtually in the home, or the participant can come into the clinic. And then at the end, there's a repeat where we do post-intervention testing with the same surveys. Surveys include the UHDRS, a grouped PEG test. So that's one where we have someone do like a fine manual dexterity test, and then different mood assessments to check for things like anxiety or depression. At the same time, we're looking at a specialized brain scan called a magnetoencephalography, or MEG for short. That is what the image on the right shows. So we have a few participants who've undertaken this before and after, and we've seen some possibility that there might be a signal change in the magnetic fields in the motor areas. But we really can't make any type of conclusion from this, and we need more participants to be able to tell if there's any meaningful change. So if anyone's interested, all that's required is an HD diagnosis in someone that's between the age of 30 to 85 and has been on stable medications for the past month. They need to be able to move fingers and hands and not have any metal implants that would interfere with the study, but that's not all metal implants. We would like the exclusion criteria to include dementia, so people cannot have dementia or be engaged in other research studies. It's a little dependent on what the other research study is. So if anyone is interested, we'll give you our contact information at the end of this presentation, or you can talk to me or Nicole at the back during the morning. So let's move on to gene therapies in HD. So gene therapy is a technique that uses genetic material to treat or prevent a disease. So in order to understand gene therapy, we're going to spend a few minutes reviewing the basics of genetics and the basis of genetics in HD. So genetics 101, all our cells have a copy of our complete genome. So all of the instructions and blueprints for making all the proteins in our body come from our genome. And so all our cells have a copy, and it's tightly wound up into chromosomes. We get one chromosome from our mothers and one from our father. The DNA itself is made up of 4 different chemicals, which you see on the picture on the bottom left. And when a protein is needed in a cell, that piece of DNA is called up and is transcribed into RNA, which is a messenger that takes the message from the nucleus where the DNA is housed into the cytoplasm where the machinery to make a protein is, and it makes that protein. And the protein can then go on to perform the cellular functions. So let's spend a minute talking about the genetics of HD. I'm sure many of you are very familiar with this. But every case of Huntington's disease is caused by the same thing. So there's a genetic variance where there's an expansion of CAG. So those are three of the chemicals that make up. So most people have up to 26, and that's perfectly normal. And then up to 35 even doesn't cause disease. But beyond that, the increased CAG repeat will cause Huntington's because that repeat expansion in the DNA becomes a repeat expansion in the RNA, which goes to make a protein that is particularly long. So you can see on the top in the normal length protein, those red, that's where the CAG repeat is. That's where the corresponding area is in the protein. On the bottom is Huntington's disease protein. So that is a much longer area. And so when the protein is long, it gets very sticky and it clumps up, aggregating in the cells. When it aggregates in our brain cells or our neurons, it really wreaks havoc on the normal cellular function. And so what I equate this to in clinic is someone who has, for example, like a messy house. So when our houses get messy, we can trip over things or lose things, or there might be food somewhere. And it's nice because we can just clean that up. But our cells don't have a really great way of cleaning up all this extra HD protein. And so the signal that the cell gives to itself is to die. And so these cells end up dying. So if it happens to one cell in the 3 billion cells that we have, it typically is not a big deal. But because this protein is accumulating in all of these cells in the brain, all these cells end up unfortunately dying off, and that's what causes the symptoms of HD. Typically, this occurs first and foremost in a deep area of the brain called the striatum, which you can see on the image on the right. So the DNA to protein image that we see here is a little bit simplified, and it goes through a few extra steps. So in order to understand the gene therapies that we're going to talk about today, we're just going to spend a moment talking about those extra steps. So it's a very complex picture, so we're going to break it down piece by piece. But overall, what we see here is the DNA in the nucleus on the left gets transcribed to messenger RNA, sent out into the cytoplasm, and then turned into a protein. So let's just look at the very first part of this. So starting in the beginning, in our DNA, what are the gene therapies that are available? And so right now, we don't have clinical trials for any gene therapies that act in our DNA, but there are a few technologies which enable us to do that. So I'm going to briefly mention them because I do get asked about them from time to time. So the first is a zinc finger protein, which you can see in the pink box on the right. So that's the ZFP. So that's kind of a editing out of the CAG repeat. There is a preclinical trial looking at the zinc finger protein in the lab, but we're not going to go into that today because it's not really gone to humans yet. The other one that I get asked about more commonly is CRISPR. So CRISPR is a newer, very popular technology that's being used a lot in the lab and has a lot of promise. So even though there are no clinical trials with CRISPR, it has already been helpful for people with HD because it has enabled better animal models and better preclinical data. And there are several centers that are looking into CRISPR for clinical trials for HD, but we're just not there yet. Okay, so we're going to move on and talk about once the DNA has become RNA. So DNA becomes RNA, and then it moves out into the cytosol to become a protein. So in its RNA form, it's very vulnerable. And remember, our goal is to basically get rid of that last step so it never becomes a protein. And we can use the vulnerability of the RNA to target it in 3 different ways that we're going to talk about today. So the first way we're going to talk about is an ASO, or an antisense oligonucleotide. So I'm going to show you another picture of basically what this is that's a little bit simplified, just so we can talk more about the ASO. So, like we talked about, the piece of DNA is needed to make a protein. It gets called up, turned into a piece of RNA, sent out, and made into a protein. That mRNA, the messenger RNA, is very vulnerable. And it's a great spot to target to prevent it from becoming a protein. What we can do is we can create a little strand of DNA, so some nucleic acids that correspond to that RNA, send it into the cell, and when those two bind, the cell recognizes that piece of mRNA bound to the antisense oligonucleotide as abnormal. And the cell's own machinery will destroy that, break it down, and prevent it from ever becoming a protein. And so that's the way that ASOs work. In general, there are two types of ASOs. There are ASOs which target only the abnormal mRNA, and so only the abnormal Huntington protein will be prevented from being made. There are also ASOs which indiscriminately target the mRNA for the Huntington, the mutant Huntington and the non-mutant Huntington, so that no protein gets made, whether it's a normal Huntington protein or the mutated Huntington protein. So the first medication we're going to talk about is a trial for a medication called tominersen. So tominersen is an antisense oligonucleotide designed to lower the amount of mutant Huntington protein in the brain. It's administered via spinal tap. So you can see that on the image on the bottom right. So basically, take a needle, put it in the lower part of the spine where the cerebrospinal fluid is, inject the tominersen, and then it gets basically distributed throughout the CNS, the central nervous system. And so that tominersen can go throughout there by just putting it right in the lower spine. So this one has been around for a while, and there was really great data from very early trials that found that there was Huntington lowering ability. However, a few years ago, when they looked at this in humans over a longer period of time, they found that higher dose tominersen or more frequently dosed tominersen actually had people do a little bit worse. And so you can see that on the left. So what we see there is here. So this is the baseline, how people came in. And the gray lines and dots are the placebo. So that's just basically a sugar pill. The orange one is people who were dosed every 16 weeks. And the blue line is the people who were dosed every 8 weeks. And you can see that the further down that they go on the right, the worse that they get. So the blue line is actually doing worse than the people who got the placebo. And so once this data was seen, the trial was stopped. And so it was March 2021. However, analysis of specific groups within the study suggested that lower dose tominersen may benefit younger people with earlier onset disease. And so that's what led to the Generation HD2 trial. So the Generation HD2 trial is being done in a younger group, so that's 25 to 50 years old, with prodromal or early stage HD. And I think it's important to note that this is a study that's being done for people who have prodromal disease, so people who don't necessarily have motor onset yet. The goals of it are to determine side effects, changes in the amount of mutant Huntington protein in the spinal fluid, changes in imaging, and then changes in function. So for example, being able to move, think, or perform daily activities. This is at the very start. The expected end date right now is not till 2027, but it is one that is recruiting. All right, so let's move on to our other type of ASO. This is the one that targets either the normal or the mutated Huntington. The next one we're going to talk about selectively targets just the mutated Huntington. So this one is a pretty clever setup. So it uses some variation in the mutant Huntington RNA code to only target the mutated version of the allele. And that way, the healthy version can go on to create healthy Huntington protein. This was also a study that was done in earlier phases. So this was the Precision HD study. The Precision HD study a few years ago did not demonstrate that it was able to actually lower mutated Huntington. So that was also stopped in March 2021. But the company that sponsored that one went on to develop a third type of ASO, and that's what's being tested now. So it's mutant Huntington specific. It's a phase 1/2 trial. Unfortunately, it's only being done outside the USA. So it's being done in Europe, Canada, and Australia, but it's one to monitor. They have 36 participants. It's administered via lumbar puncture, and they're looking at safety, tolerability, and early results show that it is actually safe and well tolerated, and it's decreasing the amount of Huntington by more than the original trials did. So this one's, the most recent data showed that they observed about a 35% decrease. So we're going to move on to talk about the next type of therapy that targets that mRNA before it can be made into a protein. All right, so we're going to talk about these small molecules. And under the small molecules, you can see what says splicing. And so what does that mean? So when the mRNA is made, it can be put together in different ways. And so the small molecule we're going to talk about basically changes the way that it's formed to prevent it from becoming a protein. And so the way that it does that is you have two exons, meaning two areas that are expressed right next to each other. And that basically provides instructions to make a protein. What this molecule does is it inserts an extra piece of information between those two to say, stop, don't continue this, and break it down. So that piece of mRNA gets destroyed. So this is an oral splice modulator called PTC 518. So really exciting, that's an oral medication that it's not an injection into the lower back or into the brain, which we're going to talk about more in a few minutes. It reduces the level of Huntington in different animals and lab models of Huntington's disease, and it's a phase 2 clinical trial in people with very early symptoms of HD. All right, so we're going to go over a little bit of the data that's come out so far for this. So we know that this actually does decrease the amount of Huntington RNA. So what you're seeing on this graph on the top, that it says that just because that's how the dosing is. So don't worry about that. The gray line is the placebo. So you should have about 100% of our normal RNA if we're doing nothing. And that's what a placebo is, the sugar pill. It doesn't really change much, which is what we would expect. And then after we give higher doses of the PTC, the amount of Huntington RNA decreases. This is in healthy volunteers and it's in the blood, not the brain, but it's a really good sign. This is over 24 hours. So the next step was looking at how long does this effect persist? And so what you can see here is the gray line on top, that's the placebo. So someone will take the placebo and nothing really changes about their RNA, which is what we would expect. But when they take the drug, their mRNA levels of Huntington protein goes down, and it stays down for a while. It doesn't get back up for a couple of days. This is also in whole blood, so you might be wondering what's going on in the brain. So they looked at the amount of free drug that's available in the CSF, and they found that as it increases in your blood, it increases in your brain. So it's able to get into the brain. So another good sign. So initially this trial is for people with very early Huntington's, but then it expanded to include people with movement symptoms and mild difficulty with their daily tasks. And they also extended the trial from 3 to 12 months. So those are promising signs. Whenever a trial like this is changed, the FDA has to go back and take a look and make sure they're okay with the new protocol. So the FDA at this point is still thinking about this. So it's on hold in the United States, but it is ongoing in Europe and Australia, and hopefully will restart here soon. Who can participate? People above the age of 25, people with 40 to 50 CAG repeats, and those who are at or near their normal baseline functional capacity and independence scale. All right, the last type of intervention we're going to talk about to prevent Huntington protein from being made are basically a viral intervention where a virus containing helper genes is sent into the body and prevents Huntington protein from being made. So this is pretty exciting, so we're going to spend a few minutes on this one. So the AMT-130 is a gene therapy delivered directly into the striatum. So that's the area that's affected first and foremost in Huntington's disease. And the goal is to slow disease progression by interfering with the production of the protein. It's delivered by a one-time neurosurgical procedure. So in order for this protein to access the area it needs to have two steps. One, it needs to get into this very deep area of the brain that's about where, if my fingers would intersect, where you would find it. So it's hard to get there. And then it also has to get into the cell. And so we're going to talk about how we get both into the cell and into the deep part of the brain. So in order to understand this, we're going to spend a minute just talking about viruses. So viruses are able to infect us because they have spikes on their exterior shell that trick the cell into letting them in. And then typically an active virus can essentially hijack the cell's own machinery and endlessly create more viral particles. Scientists have developed a way to program a virus to use our cell's machinery to make therapeutic medication. There's a major focus on this in research right now, not just in Huntington's, but for basically across the board. It's a very exciting and promising area, but it still has some work to do. The way it works is we select a virus that does not cause illness in people. So we're much more familiar with viruses that cause illness in humans, but we interact with viruses all the time that we don't know about because they basically don't infect humans. So we pick one that does not infect humans. We keep the coding. so that the virus can actually get in the cell, and then we take out all the viral genetic material. So it's basically an empty shell, and that way we can put in what we want. So instead of having virus genes, we put in specially engineered genes, which are made to block the production of the harmful Huntington protein. So a company called Unicure has done that. They have a compound called the AMT-130. It's made up of the virus shell and the shell is from adeno-associated virus. Most of you probably haven't heard of that because it's just not one that really infects people. So it's not something that's really big in the news. But it is used a lot in research. The adeno-associated virus family has many different types. They've used type 5, but there are other types being used in different types of research. The AAV, as we call it, has been modified so the interior has a microRNA, so a little piece of RNA that is a helpful piece of genetic material, and it provides instructions to decrease the production of the abnormal Huntington protein. And so once the neuron has been treated, with the AMT-130, it actually can continuously make its own Huntington lowering molecule. So overall, this should result in reduced production of Huntington protein. And the goal is that once this is in, it will last for a very long time, possibly even for life. So that's how we get the molecule into the cell. But how do we get it into the brain? It is a one-time neurosurgical procedure that aims to reduce Huntington protein. So we have to drill a hole right in the skull with a microcatheter that gets sent in, and then the molecule is infused over several hours. So the goal of the study, the primary goal is safety. So again, the AAVs or adeno-associated viral vector therapies are newer. And so we really have to make sure that this is a safe therapy. We don't know how long this sticks around, and we don't have the years or decades of experience with using this that we do with other types of therapies. So safety is the number one concern. Tolerability is the other, making sure that the drug and the procedure are both tolerable to our patients. Understanding how long the compound sticks around for, so we absolutely don't know how long it's going to last for. And then exploratory endpoints is, does this affect progression? So that's really ultimately down the road will be the goal of understanding it, but it's in early phases. So this is something that's more exploratory at this point. The timeline for this, so there are 10 patients in a low dose cohort. So some of them were treated and some of them were given placebo. In a neurosurgical procedures or surgical procedures, the placebo is actually a sham procedure. And then there are 16 high dose. There's 16 people in the high dose group. And so patients were randomized to the treatment group or the imitation or sham surgery group. And so the study consists of a blinded 12-month core study period. So you can see on the bottom, green, someone goes through screening, making sure they're a good candidate. If they're a good candidate, they have the surgery or the sham surgery. And then they get frequent follow-ups for 1 year, during which time they're blinded. After a year, they are unblinded and have the option of crossing over into the treatment group. So today, 4 of the 6 control patients in the high dose cohort have been crossed over, and then they're followed for several more years. So the last time I talked about this, we were talking about just a minor setback. So overall, the compound was found to be well tolerated, and actually it was found to lower the mutant Huntington. So you can see that in the image on the right, that was lowered. The change in the mutant Huntington was decreased by about 50%. So that's excellent. In July of last year, there was some unexpected adverse reactions in 3 people. The study was put on hold, and in November of last year, it was determined that it was safe, everyone recovered, and so the trial has been ongoing. So what have we learned since then? So signs that it works. Total motor scores, they found that there was some improvement in both the low dose and high dose cohort with total motor score. It's important to note that the low dose cohort started first, so we have more information in that group. The total functional capacity, there was some improvement there as well. And the Unified Huntington's Disease Rating Scale, there was some small amount of improvement. And so we don't know from this data what the long-term change is going to be. These are really exploratory endpoints, but it does show that there's reason to be hopeful for this as we continue to monitor it and move forward. So the last thing I'm going to show you is just a figure that was put out by the sponsor here, and it shows the total motor score of people who receive the compound and of the controls. So the green line, those are the controls. So those are the people who received the sham surgery and did not get any medication. And you can see that it only goes to 12 months. And that's because at 12 months, they were unblinded and they get the option of switching over. What they're using as a control now is the natural history. So that is the orange dotted line. So we have a lot of information on the natural history of Huntington's disease that we can compare people to. And I just want to thank everyone for contributing to studies like Enroll HD that are observational studies, because that really makes something like this possible to use the natural history. And sometimes observational studies don't seem as exciting as the drug studies, but they're really necessary. So everyone who's participated in some of those studies has really contributed to all the research that we do. The purple line is the AMT-130 low dose, and the blue line is the AMT-130 high dose. And you can see that those are a little bit lower than the natural history. We don't have significance lines on here, but it's promising data. And so the next steps for this are they're completing the enrollment in the high dose cohort in the European clinical trial. A third cohort is ongoing in the United States. So this is an ongoing trial now here. So you can ask us more about that if you'd like. By the end of 2023, additional data should be available on the 12-month follow-up. And by early 2024, the company that's sponsoring this, Unicure or Cure, is planning on meeting with the US and EU regulators to talk about next steps and advancing the clinical development of this molecule. So I'm really glad we can end on a positive note. And I want to thank everyone for coming. And I want to thank everyone who's participated in clinical trials. Even though it doesn't always end the way we want it to end, all the information we get is hugely valuable. And so it's a very selfless and gracious gift you're giving to everyone with HD and their families by participating in these trials. So I'll be around for questions after Dr. Kumar's talk, but thank you all for listening. And I'd like to introduce Dr. Rajiv Kumar.
We are one of the major sites for all the gene therapy trials that you've heard nicely outlined by Emily. We are currently recruiting patients to participate in the PT518 splicing study that is currently on hold with the FDA. We're hoping that that will get started any day. That's an exciting study. We are also recruiting patients for the Unicure trial. We have the only patients so far who've been accepted and have passed the screening for the next cohort of individuals in the United States. And we're hoping to screen additional patients this fall. As well, we are very interested in seeing individuals who are younger with Huntington, less than the age of 50, who may qualify for the ASO Generation 2 trial. And that's what I've got written right here. So please feel free to ask us questions about these very promising gene therapies. I'm going to speak predominantly about non-gene therapies in Huntington's disease now. And I'm going to first start with the Annexon trial, which is a very interesting, unique study that we conducted in phase 2 this past year. And what we do know is that there is significant evidence of the immune system playing a role in the progression of different neurodegenerative diseases, including Huntington's disease. One component of the immune system is called the complement system. Now, to activate the complement system, which results in a cascade of inflammatory downstream events, you have to activate a molecule called C1q. And if you could block the activation of C1q, you could prevent recruitment of other immune cells, the attack by those immune cells, and damage to brain cells, what we call membrane damage. And what we see is that actually in patients with Huntington's disease, we have deposition of elements of the complement system on the synapses. That means the part that interacts between two brain cells. And these are elevated in patients who have Huntington's disease. If you look at the spinal fluid, which is a way that gives us a window into what's going on in the brain, we can see that there's elevated levels of activated complement. We can measure that by looking at a component of the complement system called C4a. As well, there is, accompanying this, evidence of ongoing brain cell loss, and that we can measure by looking at a compound called neurofilament light. So when you have more activated complement, you often have more brain cell damage and higher levels of NFL. And so if you block complement, you might be able to reduce the loss of brain cells, reduce NFL levels, and slow the progression of Huntington's disease. And that's the concept. And indeed, if you do this in animal models of Huntington's disease, there is evidence to suggest that you could slow the progression of Huntington's disease. So that's exactly what we tried doing in an open label study that we conducted this past year, in which we took 24 individuals who had Huntington's disease. We had about half the individuals in this trial in the United States were at our site. And so every 2 weeks, these individuals received infusions of this medication. to see if we could slow the progression of Huntington's disease. And these people were at very early Huntington's disease. Either they had recently developed symptoms or they were very close to the age at which we expected them to start developing symptoms based on their CAG repeat length. And we looked at blood markers and spinal fluid markers of complement activation, as well as we looked at the neurofilament light levels, as well as we measured the progression of Huntington's disease by examining the patient, looking at what we call the UHDRS. What we found is that when we gave them this medication, which blocks complement, we found that there was a reduction in downstream measures of complement activation, especially activation of the C3 component, which comes after C1, 1, 2, 3, 4, like that. And especially reduction in the activated level of C3 suggests that, in fact, we're reducing inflammation in the brain. And if we looked at the individuals at baseline, we looked at the amount of activated complement measured by the ratio of activated complement C4A compared to an unactivated complement C4, about half our patients had a high level and half had a lower level of activated complement if we just split them in the middle. And if we looked at the effect of the medication, we found that people in green, okay, who had the higher level of activated complement at the baseline, they actually had an improvement. Okay, whereas the patients in blue, those ones who have lower levels of activated complement at baseline over the course of this study, they remained stable or slightly worsened. And inconsistent with what we see in the natural history study, measured in a study like the Enroll study, but done in Europe called the TRACK HD. So we had an observational cohort as a comparison because we had no placebo-treated patients in our group. And so basically we found that during the course of the treatment, those people who had high levels of activated complement remained stable or improved. Those people who had low levels did not really benefit from the therapy. And we saw that there was a differentiation between the two groups that was statistically significant. So because we see that there seems to be excellent evidence of what we call target engagement, being able to knock down complement, and we can see that there's a difference with individuals of high level of baseline complement, suggesting that the therapy may be effective in improving and slowing the progression of Huntington's disease. We're in the planning phase of doing a large phase 3 double-blind placebo-controlled trial that's likely going to begin this spring or this summer, probably enrolling about 300 patients globally. And we will likely be a site for that study. And we'll have about, most of the patients will need to undergo, everyone will need to go undergo serial spinal fluid testing, looking at the levels of complement activation and the efficacy of the drug therapy. And most patients will need to have a high level of baseline complement, as we've seen, because those seem to be the responder individuals. Now, we recently conducted a trial called the Proof HD study, looking at the effect of a novel molecule called pridopidine. We've done many studies in patients with Huntington's disease of this promising compound. This compound activates a receptor approaching the brain called sigma-1. Now, sigma-1, when activated, is a response to stress. And if you activate sigma-1, that seems good. It seems to protect brain cells. Why? Well, it reduces their degeneration. It improves their ability to produce energy to prevent degeneration, helps them clear toxic proteins, what we call autophagy. It improves the way in which the brain cells communicate, and it reduces brain inflammation. And in previous trials of pridopidine, what we saw was that patients who had early Huntington's disease, when given the medication compared to placebo, seemed to have slower worsening of their day-to-day function, and their NFL levels, gain a measure of brain cell death, seemed to remain stable rather than increase. So that was promising in the previous studies. So we did a very large-scale global double-blind placebo-controlled study in patients who had early symptomatic Huntington's disease to see if this medication would slow functional decline, measured by the simple scale called the total functional capacity score, in which you ask, can you work? Can you manage your finances? Can you do your household chores, etc.? And so we looked at whether or not pridopidine in the study would be helpful. Unfortunately, if we look at the overall large population of patients, we did not see a difference in the functional decline in those receiving the study medication compared to placebo over about a year. However, if we look at a subgroup of individuals who had the earliest HD, and we're not on any medicines for chorea, we're not on any medicines to improve mood, those patients seem to do better. In fact, seem to have slowing of progression and seem to have slowing of not only functional progression measured by the UHDRS, but also reduction in progression of motor function. We use quantitative computer-based scores of hand function as well as foot function compared to those people receiving placebo. So these results just came out about 2 or 3 months ago. The open label study is continuing, but that study will terminate in a couple of months from now. And so the sponsor, which is called Pilenia, is looking at whether or not further studies should be done in this compound with a subgroup of individuals with very early Huntington who are not taking any medicines. Now, as you all know, the triad of Huntington symptoms includes motor problems, often mood or psychiatric problems, and importantly, cognitive problems. And in time, cognition can be very much affected and affect day-to-day function. We call that dementia. And we'd like to have some medicine that we know will work to improve memory and thinking in patients with Huntington disease. So we are studying a very novel compound called SAGE-718. This compound in preliminary studies seems to be effective in many causes of cognitive dysfunction and actually has preliminary evidence of being effective in even Alzheimer's disease. Now, this medication works on a specific signaling pathway called glutamate. Glutamate is a brain chemical that's excitatory, and it acts on a receptor for glutamate called NMDA. Now, this compound is similar to a native molecule called 24-hydroxycholesterol, and 24-hydroxycholesterol binds onto the NMDA receptor to increase the activation of the receptor when glutamate binds the NMDA receptor. So SAGE-718 acts like a native compound called 24-hydroxycholesterol, and then as a result of increasing activation of the glutamate receptor, the NMDA receptor, we see that this may have beneficial effects on memory and thinking, and even improve behavior. So with this exciting preliminary data in various forms of dementia, we are studying it in patients who have Huntington disease, who have mild cognitive difficulties, or mild dementia. And so we're doing a study called the Dimension Study, in which patients will have a 3-month double-blind placebo-controlled exposure to this medication. And then once they've completed the study, they can get long-term open-label access with no placebo. I will say anecdotally, we have had about 8 or 10 patients in the trial, and most of them anecdotally look like they are better in the open-label study. So we shall see once we have the full data analysis from the double-blind, but we are still enrolling patients who have early Huntington disease, who have mild cognitive difficulties. They do not have to have dementia. They have to have mild cognitive difficulties. Now, most patients who have been previously exposed to gene therapies like tominersen have been excluded from other clinical trials. What's nice is that we're just about to start another trial of this compound called SAGE-718, called the Surveyor study, in which individuals who have been previously exposed to tominersen, as well as others who have early Huntington who have not been exposed to tominersen, can participate. And it's a very short double-blind placebo-controlled trial, only for 4 weeks. And then they can get open-label drugs, so we can see how it's working. It's nice. And in fact, we're also going to be enrolling patients who, family members, who to serve as control subjects, who we match based on age, sex, and education to the individuals participating in the study. And it's pretty interesting because we're going to be measuring cognitive function, not by just doing the usual memory and thinking tests, but even we actually have a special driving simulator to look at cognitive responses and motor responses to driving simulated conditions. And it's a pretty interesting big computer system that we're going to be using to assess function, both in the control subjects and in patients with Huntington who are still driving. I'd like to briefly mention a trial that's in planning. It's being done by a company called Asclepios Bios. It's hard to say, that's what we call it, AskBio. And I've already talked about cholesterol a little bit. Now, we know, interestingly, that cholesterol metabolism is messed up, believe it or not, in brain cells in patients with Huntington disease. And so if you could restore normal cholesterol function by putting in a gene for this enzyme called 24-hydroxylase, that could improve the rate in which cells die and could slow the progression of Huntington's disease. And this aberrant cholesterol metabolism seems to occur because of the mutant Huntington protein that Dr. Forbes spoke about earlier. So there's going to be a phase 1/2 study of viral therapy, like you saw in the Unicure therapy, where we're knocking down mutant Huntington. But in this case, we're inserting a gene for 24-hydroxylase to try to slow the progression of Huntington's disease. This study is likely going to begin in the second half of next year. And it's a surgical study in which we inject the viral vector into the brain to insert this gene. So lastly, I'd like to briefly mention a drug that was recently approved for treatment of Huntington-associated chorea. We participated in the Connect HD study of valbenazine. Valbenazine is what we call a VMAT, or vesicle monoamine transporter type 2 inhibitor. So when you give medications that are VMAT2 inhibitors, which include valbenazine, tetrabenazine, and deutetrabenazine, which is marketed as Austedo, you deplete dopamine. Okay, excess dopamine release in the Huntington brain causes chorea. So if you can reduce dopamine release, you could reduce chorea, and that's exactly what this medication does. And it works in the same way as the two other approved medications for Huntington chorea, tetrabenazine, deutetrabenazine. It has similar side effects such as sleepiness and fatigue, but generally tends to be well tolerated. And we can see if we compare chorea scores. In blue, we have the placebo group. In reddish purple, we have the treatment group. And we can see, starting by about week 2, when you're titrating up the medication, we see a separation from placebo. And we see a moderate but important improvement in chorea once you get to the stabilized doses for patients. So this is a valuable new addition to our armamentarium to treat troublesome chorea for patients with Huntington's disease. Now, Dr. Forbes mentioned the importance of observational studies. I would encourage all of you to consider participating in the Enroll HD study. We are a site, we're one of the largest sites in the world for the Enroll HD study, and it's a very simple study. It doesn't involve any medicine. It involves taking about 2 hours every time, once per year. And individuals who are affected by Huntington, individuals who are at risk of Huntington, whether or not they're gene tested or not, people who are gene positive, people who have been tested and been gene negative, and even family members who are control subjects can participate in the study. And what we do is we talk to you, we take a little history about how you're doing, we do a motor examination, we do some memory and thinking tests, we give you some surveys, and then we do a blood test to look at biomarkers. And there now, I've got 16,000, but now more than 25,000 individuals worldwide are participating in the study. And the purpose of this study is to better understand how Huntington varies from person to person, how it progresses based on age, sex, degree of CAG repeat length, and also, extremely importantly, to develop biomarkers, okay, to allow us to assess the progression of Huntington disease. You've heard that we have a lot of interesting trials, but we have limited numbers of patients who've got Huntington. We need to speed up drug development because time is wasting. We need to find out therapies that will improve symptoms, but more importantly, slow or stop the progression of Huntington disease. These trials take a lot of patients and take a lot of time. We need to accelerate that. Well, if we have to wait for people to progress clinically and get worse, that's a shame because it takes a long time. And those people are waiting to get on the right therapy. So if we can develop some blood or spinal fluid markers of progression that are more sensitive and quicker to show us whether or not the treatment is working or not, that will be helpful. The Enroll HD study is all about that. We're trying to develop better blood markers and spinal fluid markers of progression of disease. And in fact, a spin-off study called HD Clarity study, which we're doing, looks now not just the blood markers that we're looking at in Enroll, but also spinal fluid markers. So individuals who are in Enroll can also participate in the Clarity study, in which we do a spinal fluid test to help us better determine markers of disease progression. And remember, I mentioned that compound called NFL, or neurofilament light. The fact that we know that neurofilament light worsens over time and is a marker of disease progression, that was discovered as a result of the Enroll and the Clarity studies. And in fact, that's now being used as a marker for many other diseases like multiple sclerosis and ALS, even Parkinson's disease, because of the work done in Huntington's disease, because it's shown to be a marker non-specifically of brain cell loss. So we can use it in many brain therapies. So the work of volunteers who participate in these studies has allowed us to discover something that's a really important marker. We need more markers like that that are Huntington specific to allow us to advance the therapies more quickly. So I would encourage all of you to participate in the Enroll study. I would encourage all of you to consider, if you're participating in the Enroll study, to participate in the Clarity study. And the Clarity study involves a spinal fluid test. It's a pretty easy test. It takes about 30 minutes. We do it in the office. It involves taking them up, putting a small needle between the bones of the spine to remove some spinal fluid. We do that under ultrasound guidance. It's generally extremely well tolerated. And the risks are mainly headache, and that risk is about 1%. It's a very well-tolerated procedure overall. And we hope that patients who participate in the initial lumbar puncture, where we take off spinal fluid, will now participate in serial testing, where we're looking at it yearly for about 4 years, so we can see what the progression of these biomarkers is over time. Again, so we can develop an observational cohort to compare it to individuals who are getting a new drug therapy for various biomarkers. So I've mentioned about NFL, and NFL progresses from pre-symptomatic through symptomatic phases of Huntington's disease and increases as brain cell loss progresses. So that's a very nice marker, but we need better and more markers too. So hopefully myself, as well as Dr. Forbes, have been enough of a cheerleader to encourage you all to consider participating in observational and other trials of Huntington, because this is how we're going to lick Huntington's disease. And by participating in trial, you get a lot of care, because we care about you. And we want to give you the best access to new therapies. It also is a real source of hope, I would say. And it's something that you can do to help not only yourself, but help others. So it's a very meaningful thing to do. So I would encourage you to speak to Dr. Forbes and myself about opportunities to participate in various clinical trials. And we've mentioned many of these trials, such as Enroll, Clarity, the SAGE-718 trial, the Unicure study gene therapy trial, the PTC trial, the HD generation trial. And we don't want funding or access to be a barrier. I mean, we have funding, we have travel funds, we have grants to help people who have trouble getting to our site. I mean, we can send car service even to pick up people who can't drive to come to our site, all for free for many of these studies. So I encourage you to talk to us about that so we can help people who want to be involved to get involved. Our goal is not only to treat Huntington, our goal is not only to slow Huntington, but it's to prevent Huntington. We need to move our therapies beyond where they are now so we can implement them long before symptoms begin, so we can prevent Huntington's symptoms from ever happening. That's really the goal of all of our work through the years. So I thank you all for your attention. I would encourage you all at the breaks to go visit the tables in the back. Go talk to the research coordinators over there, Jessica and Melanie. Please wave, please wave. Go talk to Jessica and Melanie. Okay, I think Dr. Forbes and maybe one of our colleagues will be at the University of Colorado table. Please go talk to them about how you can help out. I thank you for your attention. So, Dr. Forbes, come on up. We're happy to take some questions for a few minutes, please. So one is clinicaltrials.gov is a good source of looking at trials throughout the country. The HDSA and the HDSA have a clinical trials finder. So look on those websites to look for additional clinical trials. As well, you can call here, take a picture of this. You can call Liza or Melanie or email them. They know about all the trials, all the centers, and throughout the United States. We can help you get connected to trial centers throughout the United States. They'd be happy to do so for your loved ones. Also, frankly, because a lot of these trials have very small numbers of individuals, there may not be a trial site that close. And believe it or not, Denver is very centrally located in the United States, as you might figure out. So we have actually patients flying from all over the United States to our site. And we fly the patient and their caregiver back and forth totally for free to participate in many of these studies. So there's that option too, if there isn't a site close to your loved one. So we're happy to connect individuals, but there are web resources as well. There are some people who will be happy to help out. Thank you.
Yeah, big thank you to Drs. Kumar and Dr. Forbes. We're in a very fortunate situation in Colorado that we have 2 HDSA centers of excellence. So please make sure, get connected with them. They're fabulous directors who are very passionate about HD and the HD community. So definitely recommend getting involved. My pleasure to introduce our next speaker, Megan Smith Cunningham. She's a licensed clinical social worker who specializes in mental health and grief care, who does have experience in neurology and with the HD community as well. So let's welcome up Megan.
Thank you all for having me here today. It's a pleasure to speak with everyone. I've worked with the HD community for about 6 years in different capacities. And I always tell people, well, I don't know how many people in this room I've told, but I've learned more from our HD families than I've learned from the doctors, with all due respect. And so I'm taking a little bit of a different approach than the docs. We're not going to talk about scientific research as much as the importance of planning. And no matter what stage you are in with Huntington's disease or where your family is within the disease. And of course, we all know there's different parts of Huntington's disease in different stages. So I'm trying to take a pretty broad approach when talking about this, just keeping that in mind. So plan, right? Everyone says that, and I don't want to sound like Susie Orman, you know, on PBS talking about the importance of financial planning, but we can't dismiss the importance of it within living our lives, whether we have HD or not. And I think it's even more critical for our families who do have HD in their family. So when you plan, remember to keep your family members and friends as part of that plan whenever possible, right? And we also can't disregard the importance of love within that planning. So we can love, and the more you start planning at this stage and loving at any stage for that matter, it's always better. So whether you started planning when you were 20, 30, or 40, and whenever your loved one or you have HD, the more planning you've put in beforehand is going to pay off. And again, I'm not speaking from personal experience. I don't have HD in my family, but this is what I've learned from meeting with many families over the years. So these are a few quotes I wanted to put up here because I just think they're important to think about. So there can be a lot of worry when we talk about HD, not knowing maybe how it's going to progress, if we even have it for that matter, or if we're going to get it, and or if we know what our number is, so to speak, whether it's 42 or 39 or 57 or whatever the repeat is. But maybe we should think about letting our advanced worrying become advanced thinking and planning, and knowing where to put that in relation to social context. So I always think of what Warren Buffett says is that someone is sitting in the shade today because someone else planted a tree a long time ago. And I think we can think of that as research and science, but we can also think about that as financial and social and a lot of other different aspects where love really comes in place within this disease. And it wasn't raining when Noah built the ark. I almost didn't put that one in here because I know there's a lot of tears within this disease. And I know that sometimes we're born into knowing our family has HD and sometimes we don't know. But planning is an important step in this process. So, and I recently read this, a patient sent it to me, and I wanted to read it because it means a lot to me. We all know Albert Einstein was a scientist, and I think it's important to remember this. And this is quote, "When I proposed the theory of relativity, very few understood me." This is a letter to his daughter, by the way. "And what I will reveal now to transmit to mankind will also collide with the misunderstanding and prejudice in the world. I ask you to guard this letter as long as necessary, years, decades, until society is advanced enough to accept what I will explain below. There is an extremely powerful force so far science has not found a formal explanation to, and it is the force that includes and governs all others, and is even behind any phenomenon operating in the universe and has not yet been identified to us. This universal force is love. When scientists looked for a unified theory of the universe, they forgot the most powerful unseen force. Love is light that enlightens those who give and receive it. Love is gravity because it makes some people feel attracted to others. Love is power because it multiplies the best we have and allows humanity not to be extinguished in their blind selfishness. Love unfolds and reveals. For love, we live and die." So that being said, I kind of want to continue on here. I want you to think about who's in your corner, because having the right people in their corner makes a huge difference. And so are these people who are in your corner, whether they're family, friends, colleagues, doctors, counselors, psychiatrists, therapists, social workers, are they supporting and helping you emotionally? And I'm not just talking about people who have Huntington's disease. I'm talking about people who may be pre-symptomatic, genetic testing. I'm talking about caregivers. I'm talking about the doctors who care for people, the social workers who care for people, who are in your corner, and are they able to fill that need? And what is their role in the relationship? What's your role in the relationship as the patient or the caregiver? Identify these people, understand their role that they play, because it can be very fearful to have these conversations, but I think it's really important that we all face that fear and have that conversation. Okay. Therapy, counseling, and getting help. Oh gosh. Okay. So with all due respect, that's the big question I get. The doctors run to me and they're like, oh my gosh, Megan, you have to help me find a psychiatrist and a social worker and a therapist who knows Huntington's disease. Well, let me tell you how many therapists really know about Huntington's disease. Very, very few. So what I tell people is you need to have someone who you have an incredible amount of rapport with, and you can build that. And guess what? They can learn about Huntington's disease because you can teach them about it. That also being said, some people really do want someone who has a background with neurodegenerative disease, and I respect that. So what I tell people often is I'm willing to talk to their therapist as a professional and explain how devastating this disease is to our families and their loved ones, and give them more of a professional insight into how that can affect somebody psychologically. And I think that any social worker who works within the realm of Huntington's disease would, I hope, be willing to have that same conversation professionally with a therapist. Okay. Please do not discount the importance of good insurance if and when possible. Oh my gosh, if I could have this conversation before everyone entered a clinic, I would. I wish I could have a billboard for people with rare disease that says, if you're pre-symptomatic, talk to a genetic counselor before you see a neurologist, talk to a social worker. If you need to get these insurances on the private market, and I'm not talking about health insurance, I'm talking about life insurance, long-term care insurance, things that honestly people aren't usually putting in place at 25, right? Talk to a social worker. Have that loved one talk to a social worker who knows about Huntington's disease so they can get that person to the right person before they see a doctor. I understand that's not always possible, but I cannot tell you how much I've learned over the years from this. And also, we have resources, and I'm willing to provide those to everyone after this presentation. So life insurance and long-term care insurance on the private market. This is kind of what I talked about. This is something important to consider prior to your knowledge of having Huntington's disease, as you will not be able to receive these types of insurances on the private market after a formal diagnosis, whether it is from a genetic testing, physical exam, or both. Consider having these conversations with those in your family who have not been diagnosed with Huntington's disease. This is key. I recommend seeing a broker who is very knowledgeable in the market and can assist you in applying for these types of insurances. I also suggest that if you do not go through a broker and you decide to apply for these on your own, that if it ever asks about Huntington's disease in your family or a neurological condition, that you do not continue the application as they all share information. So if you reveal the information about your family, you will likely not get long-term or lifetime or life insurance on the private market. So it's not like HIPAA where we can't share your information. They will. You give them the permission to share it with each other. Some insurances specifically ask about Huntington's disease, others do not, and that's why I suggest a knowledgeable broker. working, FMLA, short and long-term disability. Well, as you probably understand, like someone who's been diagnosed with Huntington's disease, whether pre-symptomatically or not, often can continue to work. And if you can, we want you to be able to take care and take advantage, I should say, of everything that's offered through your employer. So again, you really need to talk to your HR department about this. Every state is a little bit different. In the state of Colorado, we are an at-will state, which means somebody could get fired for any reason. My hope is that you have an amazing supervisor. Anytime you tell somebody about a disability who's a superior to you in the state of Colorado, you should not be discriminated against because of that. And you can discuss that with your HR department as well if you don't want to talk about it with your direct supervisor. The SSDI program. Oh, this fun program. Okay, so it's great, right? You pay into it your whole life if you've been working and paying into it. Some people pay into para if they're teachers or state employees. There's different programs. But the majority of us pay into Social Security. And this money is available to people who become disabled at no fault of their own. Unfortunately, there is a 2-year wait period for Medicare. We are not under the I'm sorry, I'm forgetting the name of the act right now. HDSA is working closely with legislators to ensure that hopefully we can get under the compassion allowance law and you may already know that, where Medicare would be available directly after being determined disabled. But at this point, unfortunately, if you become permanently disabled, you will not get Medicare for 2 years with this disease. Different types of Colorado Medicaid. I know everyone's in a different place, but there's health insurance, there's Medicaid buy-in, and there is long-term care Medicaid. Health insurance is for people who are making under a certain amount of money, and it depends on how many people are in your family. Medicaid buy-in, which is Colorado, we are one of the more, I would say, fair states as far as Medicaid goes. Of course, it is a federal benefit, but it is ran from the state. A Medicaid buy-in means is that if you're actively working even 1 hour a day, and you have proof, you can actually buy into Medicaid. And sometimes this is a loophole for some of our families, and the roof, for lack of better terms. Because if you are considered permanently disabled and you can't afford or get Medicare, or you can't get Medicare yet, and you can work even 1 hour a week, you have to show that you're actually being paid. You can buy into Medicaid for a very small amount of money and have good insurance. Don't tell them I told you all this. But it is a loophole, and I highly suggest it to our people who become permanently disabled and aren't getting Medicare. Long-term care Medicaid, that is when you are permanently disabled and you would be living in a nursing home otherwise. Long-term care Medicaid was put in place so that you can stay at home and have this care brought to your home. It is not 24 hours a day, but there is a level of support and care that will come into your home. Okay, trust. Again, I am not a professional. I am not a lawyer, but I want to let you know that trusts are important and valued for our patients. And actually, I have a little bit more information on this that isn't typed up here that I wanted to give you. Protecting your assets from the beginning, of putting your money in a safe place in case you need a higher level of care in the future. Your money is protected and it can go further. Legal advice is highly recommended in this area. I want to let you know that there is what's called a special needs trust, and HD patients fall under this special needs trust. Most people, when they think of special needs trust, they think of like a parent with a child who has a disability, right? But through what's called the Special Needs Fairness Act, a federal act passed, you can actually set this trust up for yourself. And that is a huge benefit for our families with HD, because what can happen in the future is if you need to access money, but you still need to get all these other benefits put in place, like long-term care, Medicaid, things of that sort. This money is protected, and it won't come into play when you may have to become eligible for long-term care Medicaid. I want to let you know, no matter how wealthy you are or how poor you are, most people at some point in the United States who need nursing level care will end up needing long-term care Medicaid. So that's a whole different conversation, but I just like to let people know that. So when you have a trust in place, your Medicaid, whether it's health insurance, long-term care Medicaid, or any buy-in Medicaid, even your trust money is not taken into determination to get those benefits, whether it's $1,000 or $1 million. So that all being said, I highly recommend that you get support and education through the National and Rocky Mountain HDSA Center. Our chapter, I should say, we have a wonderful social worker there, and she can help navigate these things. State and federal benefits, Social Security. I would love to give you all more information about like getting certain people in place. Working for CU, we're not really supposed to tell people, oh, this is the person you should go to. But I don't work for CU anymore, so that doesn't matter. Come ask me. I'll let you know. So disability, elder law, trust, estate, legal advice, life insurance and long-term insurance brokers, long-term care facilities. This is what your social worker is good for, is if she can't be the person or he can't be the person that does it for you, they're going to help you get to the right person. So I hope that was all very helpful, and thank you for letting me speak today.
All right, everyone, we're going to go ahead and kind of kick off second half of presentations for today. Hope you enjoyed the break. I hope you got a chance to visit with the tables with our generous sponsors, who thank you again for making today possible. So next up, we are going to invite Phyllis Foxworth, who is a manager of advocacy at the Huntington's Disease Society of America. She'll be speaking with us about different types of advocacy, as well as the string of wins that's created in pursuit of this goal. So thank you, Phyllis.
Hello, everyone. Can you hear me? I have a booming voice, so you may have to tell me to back it off a little. I don't know, but that's a good quality for an advocate. So thank you for allowing me to talk to you today a little bit about the HDSA advocacy program, and thank you for allowing me to be here on such a beautiful day in Denver. I am from the Midwest. I'm from Chicago, so whenever I get out to the western part of the country, I just relish in its beauty. I took a walk just to warm up because I was cold in here, and just looking at those mountains, we all take for granted where we live, and don't take it for granted that you live in a very beautiful place. So anyways, so I'm here to talk to you about advocacy, and one of the first things I want to say is that advocacy is available to anyone. It can be a part of an individual wellness toolkit. Before coming to HDSA in May, I was for 10 years the director of the advocacy program for the depression and bipolar support alliance. And so I was able to witness there where people involved in advocacy could really feel empowered in their lives. But it's also recognizing that families and people living with HD can often be overwhelmed, and that maybe you don't have the time in your life to take on something else. But our advocacy program is open to everyone. So when you're listening to my conversation with you today, think about others. Think about people that have, that say, how can I help? What can I do to help? They might want to get interested and get involved in the HDSA advocacy program. It's an easy way to help. So first, I want to share with you what is the guiding principle for the HDSA's advocacy program. We support family members in claiming their own power to alter the relationships of its institutions holding them. And it's together that we create a string of wins in pursuit of our goal to improve the lives of everyone with HD and their families. So just a couple key things to point out there. It's about claiming your own power. We all have power. We all have individual power. We just have to claim it. And we have to claim it and alter those relationships with the institutions that are holding them. And we do that very strategically. And we do that by creating a string of wins. We bring together wins. And by doing that, by claiming our own power, by altering our relationships with those institutions that are holding the power, and stringing together those wins, we become a mighty force to be reckoned with. So just think about some of the movements that you might be aware of. It's like, gosh, they've really done a lot, and they did it so quickly. Well, they claimed their power. They altered the relationships they had with those institutions holding power, and they strung together wins so that they became a mighty force to be reckoned with. So that's our guiding principle. So just a few moments first to talk about what are the different types of advocacy. I've outlined 3 here. All are important, but each has a different set of goals and outcomes. So the first one is self-advocacy. The fact that you're here today, you're participating in self-advocacy, taking care of yourself. We've heard this morning about clinical trials. People who participate in clinical trials, they're participating in self-advocacy. So the important part, of self-advocacy is recognizing where you need to, help and advocating for yourself. And your family member, your loved one might be doing that for you as well. The second example of advocacy I'm going to put out here is individual advocacy. And that's advocacy that mobilizes around an individual to elevate a cause. When I was at the HDSA Education Day at Vanderbilt, someone, a social worker, asked me if I had heard of the book, The Other Gilmore. Has anybody heard the book, The Other Gilmore? So that's a story that came from This American Life, and it turned into a book. It was a story about a doctor in Asheville, North Carolina. His name was Dr. Benjamin Gilmer, and he discovered that the doctor who had left, who he took over for, was named Vincent Gilmer. And he learned that this beloved doctor in this rural area had murdered his father and was in prison. And he thought, how could this be? Everyone loved his doctor. And so he started working with an NPR journalist, and they dug into it. He was in prison. And what they dug into, which he did not know, was that he had Huntington's disease. And so they really activated and mobilized around this man who the symptoms of his disease, didn't know he had Huntington's disease. His father had Huntington's disease. And so he's now been released from prison, but he's actually still in prison because into a psychiatric hospital, but they don't have a bed. But the point is, that's individual. It's rallying a cause around an individual, and in doing that, you elevate, your cause. We can think of all kinds of ways in which, a movement has formed around an individual and it's elevated that cause. But the one I'm going to talk to you today about is systemic advocacy, and that's about changing policy. That's about looking at breaking down systems that aren't working and altering them so that they do work for us. So that's what I'm going to focus. So I have 8 principles to bring about systemic change that I use when I think about systemic change. And the first one is to create a robust case for change. And that's, it's using science-based data that tells people why something needs to be changed. For example, there was a survey that we had sent out in the spring from Paulson Bartlett, our manager of disability, asking people, we came up here from our social worker here, asking people about what was their experience applying for Social Security disability income, and especially around that compassionate allowance. So we collected data because all you guys answered that survey, and we were able to get hard facts. So then you take that hard data and you make that information accessible. Before I worked in advocacy, I worked in the information technology industry and product marketing communications. And so what I always learned that when I brought there was that you have to tailor your message to the audience. So you have to package up that information. So if we're talking to the legislators, the way we present that information about what we learned from that survey. If you're talking to the media, there's a different way I'm going to talk about it. I'm talking to you. There's a different way I'm going to package that. So you have to make the information accessible. And then you need to create collaborations. There is no organization that can go it alone. Now, I'm thinking about a large organization would think AARP. AARP is a very large organization. They can't get their work done alone. They have to work with other organizations. And so that's what we do at HDSA. We join coalitions. We join with other patient advocacy organizations. One of the coalitions that we joined is the Mental Health Liaison Group, for example. That's a coalition of national patient advocacy organizations that are focused on mental health. We all know the role mental health plays in Huntington's disease. So we join coalitions. That way we are much stronger. We find areas where we have synergies, where we have common causes, and we can work together. Now it's not just HD doing it alone. And then the next couple are that, once you created that robust case for change, you packaged it in a way, you're communicating it, you created these coalitions to help you. Now it's not enough to say, okay, that's great. We have to come up with a solution. We have to put forward what the solution. We can't sit back and wait for someone to say, boy, that's really awful. Let's think of some solutions for you. That's not going to happen. So the next several steps are creating solutions, taking them out, testing them, getting proof of concept. That number 7, I think, is the most difficult, but it's the most powerful. And that's to shift culture, mindset, and behaviors. How do you shift that institution holding power? How do you shift that mindset? Thinking of the Social Security Administration, we know they're not following their rules about compassionate allowance. How do we get them to shift their mindset? But when we do, what happens? They become an ally. They're no longer an adversary. They become an ally and they're working with us instead of against us. And number 8 is just that, you keep doing it. It never ends. Advocacy never ends. You're always, going back to step number 1, starting over again. So where do we apply these principles? Who are the stakeholders? In this graph, there's no hierarchy here. I just had to throw them up there on the board somehow, but I'm just going to go around the clock. That doesn't mean that that's the most important. Those hierarchies change all the time. So government agencies. So who are government agencies? FDA, we talked about that in our clinical trials. How do we get the FDA? We've got great work going on. How do we get them to accelerate the approval of all that great work that's going on? So we have to work with them to become a mighty force to be reckoned with as a powerful group of people say we want those therapeutic interventions to come to market. We want that to accelerate the approval. NIH, National Institute of Health. What are they doing with the funding from the government? How much fair share is going to do research for Huntington's disease? So those are examples of government agencies. Elected officials, that's your representative, your 2 senators. I didn't throw the president in there because he really is the chief boss of those government agencies. So that's where the president comes in. Funders, people who give HDSA money. I can't stand here and do this work if HDSA doesn't have any funds. So there we have to share. We have to tell them what we're doing, explain to them what we're doing and why it's so important. Social service agencies or other stakeholders. I'm sure that your social workers will be able to tell you the great work that those social service agencies do. Examples that why don't you just shout out for us some of them that the social service agencies do? Right?
Human services in general.
Yeah, transportation, we talked about transportation. Senior support, yeah. So we need to, we need to alter our relationships with those social service agencies and make sure that the families and patients with HD are getting equity and getting their fair share. And then there's the private sector. And when I say the private sector, I always want to, point the finger and say, that's you. You're the private sector, so my job is to motivate and, mobilize you to make sure that you want to participate in bringing about that systemic change. All right, so we have some principles of systemic change. We have stakeholders we want to influence. How do we go about doing it? First is that we need to create awareness. And that I cannot tell you how important it is. In fact, I don't even need to tell you how important it is. I'm sure that you can all think of conditions and diseases and patient advocacy organizations like, how come they're getting it all? Because they created awareness. That's simple. They created awareness. And we need to create awareness around HD. So I'm going to share with you some ways in which we can do that. The second pillar is to drive the conversation. There's an age-old saying in the advocacy world that if you're not at the table, you're on the menu. And what does that mean? It means that if you're not at the table, you're exposing yourself to get eaten. And I say that's very passé. That's way, the odds, the 2000s. Because we have progressed as patient advocacy organizations way beyond being asked to be at the table. We have a seat at the table. We've had a seat at the table for a long time. It's not enough to have a seat at the table. We need to be setting the table. And we do that by driving the conversation. So if we can create awareness, if we can drive the conversation, now we have the power to alter those relationships with the institutions that are holding power, and we can influence legislation and policy. So I'm just going to share with you a couple examples of what we've done. We're doing this the rest of this year, taking examples of what we have just gone through of our approach to advocacy. So on the right, I've listed those 8 principles of advocacy. And on the top bar there, I've listed, the example of that I'm going to talk about, and where those 3, which of those 8 principles of advocacy are being used. And I've also used those icons from the previous slide, awareness, driving the conversation, and setting the table, to kind of show you how this program is working with those strategies. So I'm going to talk about the Social Security Disability Income Program. Thank you all who answered that survey, because we got some very hard facts. Do you know that because Huntington's disease is listed as one of the conditions for compassionate allowance, the rule in the Social Security Administration is that you jump to the head of the line, that you're supposed to have your claim approved within 3 to 6 months, because you took the time to be an advocate and responded to that survey. We know that's not true. So we had a meeting with Senator Casey's office earlier this month, the staff of Senator Casey's office, and we had a nice infographic. Thank you. We packaged it up for him, and we talked to him about why this was what was wrong at the Social Security Administration. But we also know that that it's not going to just be HD. If you just walk with HD and say, well, that's interesting. But there's 100 different diseases and conditions that are listed on that compassionate allowance. So if you don't think that I'm going after and contacting those different conditions and saying, hey, we've got this great information, I bet your folks are getting the same lousy treatment. Let's work together. So now it's not HD going to the Social Security Administration and being a minimal power to be reckoned with. We become a mighty force to be reckoned with when we bring all these other organizations with us. So that's an example of how we would be driving the conversation because we're bringing it to them. We got the information and we're creating awareness about the problem. All right, the other example that I want to share with you is just this past week, October 10th. I guess that was last week, right? We held a congressional briefing. So many of you have seen a congressional hearing where there's the representatives and the senators are sitting up on this big table and they're looking down at the people that are sitting at the table down there. That's a congressional hearing. It's like they ask experts to come in and they stand up there and they ask them a bunch of questions. A congressional briefing is the opposite. It's where the public says, I want you to come to my hearing. And so you get a sponsor, you get someone to sponsor your congressional briefing, a representative or a senator, and they get you a room in one of the office buildings that the representatives and senators where they have their offices, and you send out invitations. And you invite the representatives, the senators, and staffers to come to your hearing. And so we sit at the dais and we talk to them. And so that's what a congressional briefing is. And we did that October 10th with again, talk about coalition. So again, we set the stage. We didn't wait for people to come and have a hearing and ask us to come and tell them. We said, no, we're going to set the stage and tell you what we want you to know. And we did it with coalition. We did it with the American Foundation for Suicide Prevention, and we did it with the Truck Association of America. And the topic was on chronic conditions and suicide, which is it was Mental Health Awareness Day on October 10th. And that's a very important topic that needs to have light shed on it and to be talked about with, especially at the level of policymakers. The Director of Legislation for the National Institute of Mental Health was at that congressional briefing, and so I was able to have scheduled a follow-up meeting with the National Institute of Mental Health specifically to talk about the mental health challenges that people with Huntington's disease face. So those are ways in which we set the table, and because we're setting the table and creating awareness, we're able to start influencing policy and legislation. So over there at the HDSA chapter table, you find this postcard. In order to move forward and create an advocacy portfolio, I need to hear from you. You need to tell me what's important to you. So on that postcard, there's a little QR code that you can scan. It's also written in tiny type there, where you can go and take a survey that will share with me what is important to you, the community. What are your priorities? Because it's not about Phyllis. It doesn't matter what my priorities are. It matters what your priorities are. So go grab one of these cards, scan the QR code or read the little tiny print and go to our website and take that survey. Then I'll be able to work with others to understand what are the policy that where should we be setting the table and creating awareness so that we can bring about that systemic change. I mean, one of the things that I just always want to mention is that, yes, we need to meet the needs of the community. We need to be focused. One of the things that I always share with advocates is that if you do everything, you do nothing. And so you have to be focused. So when maybe your pet project doesn't make the list, please don't be angry. I always, when I use the environment as an example, if you were an environmental advocacy organization and you want to do everything, you want clean water and clean air and protecting the birds, well, you would get nothing done. But we have the Sierra Club, and we have, the other organizations that focus just on that. So it's important to be focused, because that enables you to accomplish it. And it's through that focus, if you remember, you string together wins. And by being focused, you can string together wins, be a mighty force to be reckoned with. And then we also just have to make sure we're looking at the capacity. How much capacity does HDSA have? And then that really plays into focus. But most important, I need to hear from you. So you need to tell me what's most important to you so I know where to focus HDSA energy. All right, so you can go to the HDSA website. There is out there a take action page. One of the things that I'm going to be doing for the rest of the year is an awareness campaign. And that's where I'm going to be asking people to register and sign up and to make it very easy for you to send letters to your representative and your 2 senators to discuss HDSA and unmet needs. Because right now, I'll be honest with you, and I don't think that I have to, I'm not telling you anything you don't know. We're kind of in a do-nothing Congress right now, right? But what we can do is be laying the foundation for a get to work Congress when we get one. So we don't want to wait until we get a Congress that's active again. We want to be creating awareness about HD now, so that when they are ready, they know they've heard about us and they're ready to start taking some action with us. So you can go there and sign up for those alerts. You'll find a survey out there, and by signing up, you'll also be able to continue to get information from HDSA about how you can get involved. And you'll learn about most importantly, you'll learn about how to send a letter to your representatives and senators. We make it very, very easy for you. When you register, it automatically tells you who your representative and your 2 senators are, what their email address is. You don't have to do any of that. It just will automatically send it for you. So please go out there, register, and that's you will also find a survey up there. You also find up there that page some of the legislation we're following. And so you might want to include that in your letter to them about that legislation. Step therapy is a bill that was introduced in the House. For those of you who may not be familiar, we in the advocacy world call it fail first. That means that your health insurance plan tells you have to take our medication, the one we want you to take, before you can take the one that your doctor and you know is best. So that's why we call it fail first. You have to fail first on that medication before we'll pay for and allow you to take, through coverage, to take the medication that you want to take. So there's legislation out there that will address that issue. So for example, if that's something that you've been exposed to, you might want to talk about that. The other thing that I want to really take some time to talk about is our advocacy leaders program. And as I said, HDSA advocacy is open to anybody and everyone. You may feel that you just don't have the time and capacity in your life right now to take on more, but you might have a very good friend who says, how can I help? It's open to anybody. And this is for people who want to do a little more. Phyllis is only Phyllis. I go to on Saturdays, I go to education days everywhere. Then I parachuted in here and now I'm gone. So I need people in Colorado who are willing to, kind of foster what we're doing and help create this movement and mentor others to keep it going. So that's what our advocacy leaders will do. I'll give you a perfect example of that, how that works. I learned on Tuesday that Senator Braun on next Thursday, and so 8 days after I learned about it, he's the ranking member in the Senate on the Committee on Aging, and he's having a hearing on rare diseases and their unmet needs. And he's asking for stories. We didn't give people a whole heck of a lot of time, but I got out an email to those advocacy leaders on Wednesday and said, send me your stories and we'll submit a packet. But that will be on the docket, that'll be read by all those senators and their staff. As part of the permanent public document, public record. That's how you create awareness, right? And so I've been already getting response. Somebody responded and said, I went out, I know someone who has HD and they're not able to tell their story, but I went and visited with her and I had her permission. I wrote down her story as she told it to me. She was one of our advocacy leaders. At that congressional briefing, we had a psychiatrist from our Center of Excellence in the University of Pittsburgh talk about Huntington's disease and how it affects the brain. But we also had a family member who shared her family story about her father who had died by suicide. She was an advocacy leader. I've had in response to the email that I sent on Wednesday, I've had other people reach out and say, I'm talking to everybody in my community. That's what an advocacy leader does. They get information from me and they're going out and spreading it to their community, encouraging and helping others. So we'll have a nice packet that we will be able to submit next Wednesday for that hearing. The other big campaign that we're working on for 2024 is a what I call our HDSA August Recess in District Meetings campaign. So what does that mean? Means that you may or may not be aware that your elected officials come home in August. I didn't know this, but that's actually a law that they're required to go home in August. Why? Because they need to be around you. They need to hear you. So they schedule these meetings. So I'll share with you, the best time to go to DC to talk to your representative or your senator is not in DC. When I had that congressional briefing on August 10th, it was the same day that all the Republicans came back and were caucusing about who they were going to put up for Speaker of the House. And I was walking around those office buildings and I saw all the little fly-ins and I said, oh, those poor people. They just spent $100,000 bringing all these people to DC and there's nobody there. There's nobody in those offices. Nobody wants to talk to them. They got bigger things going on right now. So you don't want to go to DC to talk to your representative. You want to talk to him at home when he's here waiting and willing to talk to you. So we're creating this campaign in August called the August Recess Campaign, where our goal is to have 100 members with 100 meetings with representatives and senators back home in their district. Our advocacy leaders are going to be instrumental in working with the people in their community to make sure that those meetings are happening. So one of the things that we'll be doing next year is having a workshop in Chicago, because that's where I'm from, with those advocacy leaders, helping them get them organized to go back into their communities and get those meetings set up for us. All right. One of the things that's kind of an overview of what we're doing for advocacy. I just wanted to share with you, these are the questions that are in that advocacy survey. Remind me how much time we have? 10 minutes? All right. Well, I don't know if we'll use the whole 10 minutes, but this is the opportunity for me to hear directly from you. I still want you to take that survey. Because one of the things I didn't say back here is, how do you become an advocacy leader? You take the survey. Because the last question in the survey says, yes, I want to know more about the Advocacy Leaders Program. Because I guess I kind of figured that's my little weed out. Like, if you can't be bothered to take that first step of advocacy by taking the survey, probably I'm really interested in being an advocacy leader, and I don't want you emailing me saying, hey, send me more information about that Advocacy Leaders Program if you didn't even take the survey. So take the survey if you're interested in the Advocacy Leaders Program, and that's the last question. But I still want you to take the survey regardless, because this is where you're going to tell me where I should be focusing our energies at HDSA in bringing about systemic change. So let's just look at that first one. Access to quality health care. Is that a challenge for anybody? How about access to medication and medical devices? Is that a challenge for anyone?
Well,
Mm-hmm.
well, in terms of dealing with insurance companies,
Okay.
you know, medication prescribed by the doctor, but in terms of the insurance company, they don't recognize that as being a drug that they're approved.
That goes back to that legislation and that I talked about on that previous slide. So when you write your letter, when you respond to that awareness campaign that we're starting, that's something I hope you put in your letter, is that access to medication is a real problem when you're dealing with commercial insurance companies. How about access to skilled nursing care, regardless whether it's in home or at a facility? Is that a challenge? So let me share with you that the Health and Human Services, HHS, came out with a new rule regarding staffing requirements for skilled nursing facilities. And I want HDSA to provide comment. So when they come out with new rules, then there's an open period where you provide comment about those rules. And I think that one of the areas that we should be providing comment on is that this is great, that you're changing your requirements for staffing, but let's make sure that the staffing are people that are, that are, have the skills to live, to support people with Huntington's disease, for example. I think that would be a great way for us to comment on that. Healthcare costs, financial burden. Does anyone have any experiences, any challenges with the financial burden of those healthcare costs? All right, genetic and biomarker privacy and access to genetic counseling. Those issues for people that we should be talking about. I'll share that we were asked by Senator Cassidy sent out a request for information to stakeholders asking them to comment on whether privacy, medical records privacy in the area of research. And we specifically talked about genetics, how it's so important to be protecting the outcome of genetic testing when we're doing research, because as we just learned earlier, the challenges and the discrimination that happens when that genetic information is not protected. So we submitted comment about that, and hopefully we'll see some new rules, some new legislation about that. Well, I appreciate the dialogue and the conversation. So I mean, just in ending here, we mobilize through education. And so I hope that all of you will go watch the HDSA site. And if anything, just if you will sign up so that you get this information from us, because it's through your pretty awareness that we can make a difference. So appreciate your time today.
Big thank you to Phyllis there, and I hope that I'm one of the many people here who will be taking that survey. So that way, like she said, we can have our voices heard and really have good focused attention on the things that matter to the community. So our final presentation of that morning will be from Dr. Christina Vaughn. She is the Division Chief of Neuropalliative Care and Professor of Neurology and Medicine at the University of Colorado School of Medicine. She specializes in movement disorders and hospice and palliative medicine. And her presentation today will be on palliative and spiritual care and Huntington's, as well as practical solutions for caregivers. So please welcome Dr. Vaughn.
Hello, good morning. Thanks for the introduction. Thanks for the opportunity to be here. I've been slated for 70 minutes and I am not going to take that long. And it's especially hard because you now have a visual of lunch sitting right over there. So I hate to be the one to be in between sitting and eating, but hopefully it'll be of value. And I would love for this to be interactive. In other words, if you feel like I have said something you want to ask a question about, or add a comment about, please don't hesitate. So I'll go ahead and get started. So as you heard, I'm a neurologist and a palliative care physician. And one of the tenets, you can't really see it well there, but it says words matter. One of the tenets of palliative care is a reminder to us that words matter. And the word palliative itself, a lot of people haven't heard of it, or if they have, it conjures up all sorts of ideas. How many people in the room have heard of palliative care? It's a nice, most people. And could you just shout out some words that palliative care makes you think of, or what you associate with it? Anything, just shout it out. I'm so curious.
Love.
Love? Thank you. You're biased, but I appreciate it. I had the pleasure previously of working with Megan and Clark, so I'm lucky for that. So love, sorry?
Comfort.
Comfort, love that too, thank you.
Less stress.
Less stress. This is a self-selected audience, I'm starting to realize. Any other words though, when people hear palliative, is it a good word, a scary word, neutral? But all right, so palliative care sometimes conjures up some negative thoughts for some people. Some people get scared by the word and say, you know what, that word has a lot of charge to it. You really need to change it. And sometimes, as you heard in my introduction, You heard that I trained in hospice and palliative medicine. And a lot of times the word hospice is associated with palliative. And I'm not going to spend time talking about what palliative isn't, but I will say that palliative care and hospice are separate things. And I'm going to focus on palliative care. So what does it really mean? Conjures up a lot of different words. I heard love, comfort, and so on. I appreciate that. The word palliative, I love the word and what it really means. It comes from a word that actually means to cloak. And I love this visual because the idea of a cloak is like another layer of support, palliare. And some people say, well, it's got this negative connotation, the word palliative. Why don't you just call it something like supportive care? And I'm a purist because I know the meaning of this word, and now you do too. I prefer to use the word palliative rather than supportive care. I think it's the organist, right? Okay. All right, well, palliative care is showing up more and more in Huntington's disease. A lot of times people associate it with cancer. That's another thing I hear a lot about. Palliative care, that's for cancer patients, right? Well, actually, sure, it's for cancer patients. It's for anyone living with a life-limiting or a serious illness at any stage. So it is coming up more and more often in Huntington's disease. In fact, I'll be at the Huntington Study Group meeting, the HSG meeting in a couple of weeks to talk about palliative care there as well. So there are plenty of opportunities more and more to see palliative care showing up in the world of HD. But how else can we define it? Well, the head of palliative care at UCSF, Dr. Pantalot, describes it as a way to live as well as possible, as long as possible in the face of a serious illness. I like that as well, to distill it down. It gets a little confusing though, because people say, well, isn't that what all medicine is or supposed to be? And in fact, yeah, it is. Palliative care in a very general sense is an approach to care. It's part of basic patient care that all healthcare providers are providing, focused on good communication with the patient and the family, shared decision-making, making decisions as a team with the medical side, but also what's most important to the patient and family, as well as setting goals and focusing on symptoms. So palliative care is basic healthcare, or at least it should be. Specialty palliative care is for people that have gone and gotten extra training, and it's for more complex issues, which may or may not be covered by other services. For example, a palliative care team would be focusing on goals of care, advanced care planning, and potentially other complex symptoms. So that's what we're going to talk more about today. The idea is that a palliative care team, a specialty palliative care team, is coming alongside your main neurology or other medical teams to provide that additional layer of support to the patient and family. And I can't stress enough, it's at any stage. Some people mistakenly say, oh, palliative care, that's for later on in the course of an illness or of a condition like HD. In fact, it can be useful at the time of diagnosis. Why wouldn't we want another layer of support? We do want to be sensitive to not burden people by too many medical visits, because you could easily spend a lot of time seeing different doctors and teams and so on. So that's not what I'm suggesting, but at least meeting a palliative care team early on in the course of any serious illness or life-limiting illness can make sense. And hopefully I'll appeal that to you in a few slides. So it's definitely not high tech, it's high touch, right? There's nothing fancy about it. It's high touch. So in palliative care visits, specialty palliative care visits, we're focusing on complex symptoms. That could look like behavioral issues, sleep problems, constipation, mood problems, chorea, tremor, all those things, kind of adding on to what care is already being provided by a neurologist. We're focusing on coping and support, and we're focusing on future planning. If I could distill it down into 3 buckets, those would be the 3. Any stage. And ideally, palliative care is provided in a team, with the patient and family at the center, a medical provider, a physician or a physician assistant, a nurse practitioner, a nurse, a chaplain, and a social worker. And this is the ideal scenario. It doesn't mean that all the team members are going to be present in the visit with the patient and family. They can be asynchronous visits, but ideally, this is the sort of setup of a palliative care team. And the reason is because we recognize that living with a condition like HD is far more than just physical symptoms, right? A chaplain can be there to help with the spiritual side, which I'll get into in a few minutes. Social work, you've already heard about today, can be instrumental in a variety of ways, including resource support and counseling. So it's best provided by a team. Where can you find palliative care? There are a few different places that palliative care exists. One is in the community. community-based palliative care is a resource often not known about. You don't know what you don't know, right? Palliative care can be provided by community-based programs. Sometimes and oftentimes they're associated with a hospice, but they're separate. They're under the same umbrella, but different. Can be provided in the hospital. If patients are admitted to the hospital, there are often palliative care teams working in the hospital in a consultation. And then there are clinics, outpatient clinics, which is what we have at UC Health and Shoots, clinic-based palliative care. So you come in as you would to another medical visit into the clinic. So these are the three main places that you would find palliative care support. What are the tools of palliative care? So as you heard, I'm a neurologist, Dr. Kumar, Dr. Forbes, and so on. We're all neurologists with movement disorders training. So when we were in training, our tools were jiggling around in our white coat pocket, like the hammer, the reflex hammer, the tuning fork, the stethoscope, all these things were our tools. And that's what I relied on when I was strictly focused on neurology and movement disorders. But as I've shifted my practice to be focused on palliative care, my tools now become listening, but more than that, questions, trying to ask powerful questions. And this is what is kind of jiggling around in my brain rather than in my pocket. Instead of tools physically, the questions that I ask are the tools. And you'll see throughout the rest of this talk that powerful questions really underlie a big part of palliative care. So what are the interventions, so to speak, that we're providing when we have a palliative care visit? Well, the first I would say is the goals of care conversation, which is really an exploration rooted in the questions to try and get to know who the person is in front of us. Before seeing someone as a patient, we really want to see them as a person first. The other interventions, which I'll highlight, are we provide assistance with medical decision-making, with advanced care planning, and then support with coping. And I'll get into all of these. So what are goals of care? I used to think that goals of care simply meant, what does a patient want in terms of treatment? Somebody might say with HD, oh, I want to have my chorea focused on, I want to have less chorea. I want to walk better. I want to, something rooted in symptoms. But actually what I mean by goals of care in a palliative setting really is what matters most. What are the person's values, the person and their family? What really matters the most to them? And this is different than treatment goals or medical decision-making. This is dependent on what's going on at the time in their life, so it can change certainly over time. And as HD progresses, only the most important values are what continue to stay stable along the way. And so these are value-based goals of care. Could be anything from spending more time with family, being as independent as possible, going to a reunion, going to an event. These are what in life is most important and how can we help achieve that if possible. And so the way that we get at these kinds of questions, we don't just say, hey, what are your goals? What are your values? I think that's just too on the nose, and it's hard to actually have a conversation with those kinds of questions. And so we ask a variety of other questions, such as, what do I need to know about you as a person to give you the best care possible? It's broad, right? And that too can be hard. Sometimes people are like, well, this is a medical visit. I don't know what you want me to say. And I might say, well, have you always been from Colorado? Like sometimes that allows people to say, okay, well, let me tell you a little bit about my story. What's important about your story? That's another question that sometimes people respond well to. What are some of the things that make you you? What was life like before HD became obvious for you? What are you most proud of? What puts a smile on your face? How about you could ask someone to fill in the blank. If I could not do or be blank, it wouldn't be me anymore. Or what functions or characteristics are so important to you that you can't imagine living without them? Again, these are questions that are really provocative and allow us to try and get to know someone better outside of just what's in the medical record. We also are really keen to know who are the people that support you. What are you hoping for? What are you worried about? These are different sides of the same coin, hope and worry. And what's the hardest part of this? I think that's a particularly powerful question that gives us insight into the practical side of what life is like day to day for people living with HD. So the goals of care conversation, again, is an exploration with a bunch of questions that we hope can really evoke a robust conversation so we can try to get to know someone. And if the person in front of us, the patient, the one with the diagnosis, is unable to answer these questions, then we turn to the family or whoever's with them to try and get a sense from them. So why are we doing that? Well, certainly it feels good to get to know our patient and who's in front of us outside of just the medical record. But we're trying to really extract their values, their hopes, their goals, who they are as a person, and their life story. All of that together helps us have a better comprehensive understanding. So then we can see what's possible medically and how do we match those things up, right? So when I say what's possible medically, that could look like home health, placement, medication or clinical trials, procedures, surgeries, code status. These are all the medical side of things that when we're helping patients and families make medical decisions, we want to rely on what we've just learned from their values, their story, what's important to them, to be able to help guide them in making medical decisions. And then that becomes the treatment plan, the negotiation of goals of care and what's possible medically. So that's a goals of care conversation. What about assistance with medical decision-making? What do I mean by that? Well, informed medical decision-making is taking, what is most important to you and having all of the information about your illness or what's being presented as far as a procedure, a test, et cetera, and trying to make sense and navigate next steps. Trying to help you clarify your goals and ensure that that's clear to other medical teams. That's another key point here, because a lot of times people living with HD and other conditions are seeing a variety of different specialists, and it can be really hard to coordinate that care or communicate the same message. So we're trying to share what we've learned in these goals of care conversations with other medical teams in order to help people make informed decisions. And so, naturally, living with a chronic illness means you're likely going to have to make difficult choices that affect your well-being. And some of those questions or choices can be simply, should I enroll in clinical trial? I mean, for some people, that's a no-brainer. They're like, absolutely, I'm going to enroll in a clinical trial. I want to help push the field forward and so on. That's not the case for everyone. Some people think, well, I don't know, I don't want to be a lab rat or something like this, or I don't know what that means. That's a scary idea, and so on. And so we really try to be helpful for medical decision-making for this. And we use frameworks, for example, not just what are the risks and benefits of enrolling in a clinical trial, but what about the burden? I think it's important, and we often overlook the burden piece of participating in a trial or having some sort of treatment. What does the burden means? What does it really look like to participate in this? If your goal is to spend as much time with your family and be outside as much as possible, and you're thinking about a clinical trial that requires coming into the office, driving several hours, and having a test every week or every month, maybe that's not a good trade-off. Maybe that burden is too high. So really having discussions with people, making medical decisions rooted in risks, benefits, but also burdens. That's a framework we like to use. What about an elective surgery? A lot of our patients are being faced with, you should have this orthopedic surgery, or you should have this colonoscopy, right? That seems pretty basic. But if someone has advanced Huntington's disease, maybe a colonoscopy isn't the best plan. Maybe it is, but it's worth discussing, right? Because if someone has a colonoscopy and they go through the prep and they go through the sedation and everything, that could be really a setback for them, depending on how ill they are with HD or something else. Maybe, maybe not. And what if we find something? What if we find something abnormal on the colonoscopy? Some people say, well, yeah, I want to go and pursue it and get the next test. And if it's, God forbid, cancer, I want to get treatment. Other people say, I don't want to look for something because I'm not willing to go through chemotherapy or et cetera, because I'm already really sick or advanced in my HD, for example. So really having conversations about anything procedure-wise, from a colonoscopy to an elective surgery, we want to focus on best, worst, and most likely scenarios as another framework. So this is how palliative care teams can be helpful or want to be helpful when it comes to medical decision-making. Really getting to know someone, helping navigate and guide through medical decisions. What about advanced care planning? So advanced care planning is planning in advance for medical care, sort of thinking about the what ifs of the future. I used to think that it was called advanced care planning, and it is not advanced in any way. It's planning in advance. It's pretty basic, actually, not advanced at all. And so it's again, planning for future medical wishes if you should ever be unable to make these decisions for yourself. Now, this applies to all of us, HD, non-HD, any diagnosis or lack thereof. This applies to all of us, caregivers and so forth. So this is, pay particular attention to this part. I can't say this enough. It allows all of us to have our voice heard, even if we can't speak for ourselves, if a medical decision has to be made. 70% of people lack capacity when they're at the end of life, when medical decisions may have to be made, right? If you don't have capacity and you can't speak for yourself or speak clearly enough, then who's going to make medical decisions for you? Are they going to do it in a way that's honoring you or making a decision that you would have made if you were able to? The fact that we know that 70% of all comers don't have the ability to make medical decisions at end of life, for example, means we really ought to write our decisions down when we can earlier in life. And it's more likely if we document them that they'll be honored, right, than if we didn't document them. And it really does lower the stress, the anxiety, depression, and provides higher satisfaction in the family members, knowing that the medical decision-making has been documented and that we've had these conversations and everyone's as clear as they can be about how to honor this person or how to make medical decisions for the what ifs if they got sicker in the future. So for a lot of people, this can be an elephant in the room, thinking, oh, we haven't done that yet, or, we'll do that later when the time is right. The time's always right. I guess the time could be wrong. The time could be wrong if we're in a crisis and we haven't had this discussion, you have a medical crisis and need to make a rash decision. That would be the worst time to make these kinds of decisions. So ideally, we're having these conversations when there's no crisis and people are able to speak up for themselves. And why wouldn't we do this, right? We prepare for all sorts of emergencies in our life. During the peak of the pandemic, we were stocking up on toilet paper and everything else. We have fire insurance, we have insurance and so on. This is just another way to prepare for the what ifs of the future, is to document wishes. And so advanced care planning, very basically, is sharing your wishes, having the conversation and documenting it. And it's associated, as I said before, with satisfaction, with less stress and so on. But unfortunately, less than 10% of neurologists indicate or initiate these kinds of discussions at the time of diagnosis of a condition. I think there's a lot to talk about when somebody's first diagnosed with anything, certainly HD, right? There's plenty of things to talk about. What are we going to do next? What are our next steps? What are the treatment options of clinical trials? There's no room oftentimes for a discussion of like, hey, here's an opportunity to make sure you've got your medical power of attorney documented and your advance directives. And neurologists maybe think, well, that's probably not our job. The primary care doctor is going to do that or did that, or we assume that they've done it. But in fact, neurologists have a great opportunity to have these conversations, if not at the time of diagnosis, anytime after that, just to check in about it. So it's basically just two elements. Advanced care planning, medical power of attorney, which is thinking to yourself, who is the person I trust the most, who knows me the best, who could be my voice if I couldn't speak for myself to make medical decisions. That's the person that would channel your voice in those moments when they need to make medical decisions, and documenting it. So that's the first of the two pieces. The second is the living will, or the advance directive. This is a document signed by the patient stating what type of interventions he or she would want in the event of a critical or terminal illness, or if their medical condition changed suddenly. That's it, those two elements. And you don't actually need an attorney to generate these, particularly in Colorado. And so I'd love to give you some homework. If you haven't already done either of these things, the medical power of attorney, as I said, doesn't require an attorney. It doesn't even require a witness or a notary or any money. You just go online here in Colorado, search medical durable power of attorney, or MDPOA, print it out, fill it out, you sign it and initial it, and indicate the names of the people you would want to be as your voice. That's it. It's very easy. Interestingly, in the state of Colorado, you might not realize this. This is an all interested parties state. What does that mean? That means if you land in the emergency department and you're altered in some way, fuzzy-headed, can't speak for yourself to make a medical decision, and you're by yourself, the medical team doesn't default to calling and asking your next of kin or your spouse to make medical decisions for you. Instead, we have to assemble all interested parties who would be interested in your care, have them make a consensus on who would be your voice to make medical decisions for you, and then that person can be the voice and make those decisions for you. So we have to have it documented, particularly in Colorado. Otherwise, we have to go down this rabbit hole of assembling anyone that could be interested in your welfare to have this kind of an all interested parties meeting. And having done this on the hospital side, it can be really tedious to assemble such a group or to get them all on the phone. So this is the simple way around that. The document that you can use as an advance directive could be the 5 wishes document, for example. You can find this online as well. It really is a nice guide. I've done this with my family and I've done it for myself. It guides you into, you know, any sort of boundaries you would want to have on your care, things that wouldn't be acceptable to you, for example. So it's one example of an advance directive that you can consider, any of us can consider. And here's a handy website in our state, coloradocareplanning.org. Can be a really helpful resource. So that's the homework for all of us. And then lastly, when it comes to palliative care intervention, so to speak, the support piece, the support with coping, the support with the daily living with HD, both for the patient living with it as well as whoever's close to them. So when we're talking about a palliative care team, as I mentioned, ideally it's a team. We've got the neurologist or an advanced practice provider, a nurse, if we're lucky on the team is, and I say lucky because there's a lot of turnover in healthcare these days, but nurses are very equipped to go through medications, talk about home safety, ask who your medical power of attorney is, and screen for any caregiver distress. Chaplains, I also like to call them spiritual care counselors, because I think, as I said before, words matter, and the word chaplain sometimes takes people aback, particularly people that don't identify with the religion or any sort of spirituality. So spiritual care counselor is more often what I like to say when I'm describing these folks. They're the people that tap into your spirit and they ask questions like, how's your spirit? And I'll get into that more in a moment. And then social workers, I think, you know, as I said before, and you've heard from Megan, wear a lot of different hats and have a lot of skills. But certainly some of the skills can be connecting people with resources in the community, screening for caregiver distress, advising on financial or insurance benefits, providing counseling and support, and so forth. So let's get more into the idea of what the chaplain is and the spiritual care piece when it comes to care. And why would you need spiritual care in a medical setting? That seems rather foreign to a lot of people. And, you know, I think it's more common on the hospital side. When people are in the hospital, there are more chaplains around and you think, oh, here comes the chaplain, something's happening. You know, you can associate chaplains with hospital side, but in the clinic side, the outpatient side, chaplains can be equally, if not more helpful, because you can have a longitudinal or a long-term relationship with them. So the idea of the chaplain or the spiritual care counselor is to come alongside people who are often wrestling with the deepest questions of their reality related to purpose, sort of the why behind the what. Why is this happening to me? Goals, again, but in terms different than the goals of care that we talked about earlier, the chaplain's goals that they're focusing on are more things like, where do I want to be in my soul? Or how do I want to reconcile some relationships that are uneasy for me? They're talking about identity. Think about the change in identity that often happens when somebody is faced with a serious illness. Perhaps they were working and their identity was rooted in their career. And now, in the face of a serious illness, their identity has shifted and they're no longer working. You know, these massive shifts sometimes occur in identity, or your identity within the family. Maybe you were the breadwinner and you're not anymore. The chaplains really like to get into deep discussions about people and their identity and help perhaps ease people into a new identity or to loosen the grip on the old identity that they so identified with. They talk about meaning. They talk about connection, either to people, to the universe, to God, to nature. And those are just a smattering of kind of broader topics that chaplains or spiritual care counselors address in medical settings. It can continue to be connected to someone who had, their religious background if they have one, but it really doesn't have to. Again, when somebody hears chaplain, they think, well, I'm not religious, is a common response that we hear when we're offering, would you like to meet with a spiritual care counselor? And we try to reassure people that, oh gosh, you don't have to be religious. They're not proselytizing. They're not here to even talk about religion. If you bring it up, they'll go there with you, but that's not the agenda. And they're going to talk about any core beliefs that you have or don't have, and explore them and see how can we help you find more sources of strength in the face of living with a chronic illness. So some examples of questions that they might face from patients or family members enduring a chronic illness. Why is this happening? Why? Right? That's a common question. Why is this happening? What does it all mean? How do I make sense of all this? Even in a case like Huntington's disease, where often it's a Huntington's family, right? Where the patient with HD has been familiar, oftentimes, not always, with Huntington's. Still, there's so much room to ask these questions. How do I feel about these changes in my life? What gives me comfort? What gives me hope? Do I have either of those things? What am I grateful for? What or who do I trust? Who is my beloved community? Who loves me and who is loved by me no matter what? Really taking stock of that are some of the questions that come up in these visits with spiritual counselors. What or who beyond myself do I believe is important in my life? Checking in with that can be another way to try to tap into sources of strength in the face of living with HD. What do I call good in my life? What do I call bad? I think in the world, we're quick to label things in sort of a black and white way. This is bad, this is good. And chaplains, once again, provide provocative questions to help people really question some of these core beliefs that might be getting in the way or adding to their suffering. So how about a case example? Let's say we've got a 65-year-old gentleman, GH, with newly diagnosed Huntington's. He's not religious, he's very clear, but he believes in God. And he's asking questions in the neurology visit like, why is God punishing me? What bad things have I done to deserve this? And as a neurologist, we don't have training in how to address these questions. So thankfully, I'm very lucky. I have 3 chaplains in our clinic. They're all part-time, so they're not all at the same time, but we have access to spiritual care. So this is, of course, a trigger for me to want to get some backups, get some help from one of our spiritual care counselors. And so because this person is clearly wrestling with guilt, questioning God's role in providence, the neurologist refers him to a chaplain. So the chaplain's role in this case, he joins him in his struggle, but also points a way beyond the struggle, inviting him into hope, purpose, but not forcefully, right? In a very gentle way, once again, with questions. So the chaplain asks, how do you think God wants you to live now that you have Huntington's disease? It's an interesting question. I'm sure there's no easy answer. But these are the sorts of questions or tools that the chaplain, the spiritual counselor, is going to try and use to address this existential suffering. What are some of the sources of strength you've leaned on or turned to in the past or have access to in the present? I think a lot of us don't realize that we have strength or just assume, oh, I don't know, I'm going to flounder here, I don't know what to do. But sometimes having a discussion with a chaplain offers you an opportunity to look back on other hard times in your life and think, oh, how did I get through that? Okay, I leaned on my family. I, had a writing practice. I did something, just tuning into what worked before can be helpful. And then the chaplain asks, are there any spiritual resources or practices you have turned to and found helpful? Things like prayer, reading, meditation, etc. So this is perhaps the start of the interaction with the chaplain, starting with some questions and then thinking about, okay, what tools now? Now what? So chaplains make use of a whole variety of different strategies and tools. Again, not necessarily rooted in religion. There are mental and spiritual practices, whether it's meditation, mindfulness, slow and deep breathing, progressive muscle relaxation, biofeedback, et cetera, et cetera. You might not think, oh, why a chaplain does all those things? Well, potentially. Chaplains are well-versed in a variety of skill sets to help people feel more grounded and provide them with more tools. And so there is a long list here. They can help guide people towards creative practices, therapeutic journaling, letter writing, gratitude journal, singing, etc. They can also encourage people, depending on how they're doing, to think about service activities, volunteering, considering a pilgrimage, vigils, marches, etc. So that's another area that chaplains might tap into. Relational practices, chaplains also talk about. They can, refer people for counseling or tap into a social worker for counseling, and talk about interpersonal dynamics. Some of them are also trained as family therapists, sometimes chaplains, and so they can be skillful in talking about dynamics in families. They can also suggest support groups. It doesn't just have to be a social worker, etc. They can offer suggestions about rituals, ceremonial practices. They can talk about creating a sacred space or going on a retreat. And then lastly, some body kinetic practices and activities. They can suggest, Tai Chi, Qigong. I mean, all I want to point out here is that there's a broad array of different suggestions and potentially skill sets that some spiritual care counselors have that can help additionally support patients and families in distress in the face of a serious illness. And these are all actually listed on our website. If you want to refer to this list again, it's just neuropalliative.org in a caregiver section. But anyway, all that to say, asking questions is important, but then what, right? Then we've got to come up with some next steps. And these are often the sort of areas that chaplains might draw on. So here are two quotes that I think are certainly very powerful. This is Viktor Frankl. I'm sure many of you know who he was, an Austrian psychiatrist and Holocaust survivor. He said, "We cannot avoid suffering, but we can choose how to cope with it, find meaning in it, and move forward with renewed purpose." And I think that's the perspective a lot of our spiritual care counselors have in trying to help people not ignore the suffering, recognize it, name it, but also think about now what? Now, what do we do with it? How do we come up with some strategies to work around it or work with it? What about the topic of resilience? This comes up a lot. According to the American Psychological Association, resilience is the process of adapting well in the face of adversity, trauma, tragedy, threats, or significant sources of stress, such as family and relationship problems, serious health problems, or workplace and financial stressors. It's kind of a broad definition, but a starting point to think about the topic of resilience. What is resilience? When you think about resilience, any thoughts that come to mind? Some people say it's the ability to bounce back. Like you either have it or you don't. Other people say, well, resilience is the ability to remain flexible, like a rubber band under stress, or to bend like a tree branch in a storm. Any other thoughts on what resilience is or what it isn't? Well, it's not a characteristic trait that some people have or some people don't have, right? Which gives us all hope that we can dial up our resilience. Cultivating resilience is really a learned, ordinary process and something anyone can develop by adapting behaviors, thoughts, and actions. A lot of people think of resilience as a battery, which may be fed by physical, mental, spiritual, emotional sources. And when our batteries are low or empty, we don't have much energy or any at all to draw upon to manage our feelings, to problem solve, to make clear decisions, and to respond well in tough situations. So what is this? This is a common concept, right, of an empty vessel or an empty cup. And the idea, I know it's used a lot, but I still think it's powerful. The idea that an empty cup or an empty vessel has nothing to give. And the idea of being depleted as a person living with a chronic illness or as a caregiver comes up a lot. How do you fill that cup? And it's easier said than done, of course, right? I'm standing up here just throwing around ideas. But the goal is really to think about what matters most. How do we carve out time for it? And what's going to be most effective and helpful in helping people keep their cup somewhat or all the way filled as much as possible. And so when it comes to caregivers, there's a huge potential for care partner, caregiver distress in the face of living with Huntington's, being part of an HD family, and so forth. And a lot of people, even if they're familiar with Huntington's, can be very underprepared for this role. At the end of the day, there's really no handbook. Everyone's situation can be quite different and personalized. One case of Huntington's isn't necessarily just going to be like the next, right? Even in the same family. Roles are evolving, right? As a caregiver or as a loved one, watching your loved one have HD or something else that progresses over time, things are evolving, roles are evolving. There can be a high level of burden, certainly depression and increased mortality among caregivers, not unique to HD, amongst all caregivers in various medical situations. And caregiver burden is associated with many things, including spiritual well-being, health-related quality of life, caregiver anxiety, depression, and perceptions of their patient or their loved one's quality of life as well. It's very normal, right? I think we all know this, to have feelings of fear, anger, resentment, frustration, anxiety, grief, sadness, and guilt. And all of those things deplete the battery or deplete the cup, or however you want to think about it, are really depleting. And those emotions can happen in your face and be very obvious. And they can also happen behind the scenes in the background of our thoughts, draining our body and mind sometimes and affecting even your heart rate, your blood pressure, and so on. It can become physical. And what we really strive to do on the medical side is to try and prevent families and care partners from getting to sort of that frog in boiling water scenario where you think, how did we get here into this pot of boiling water? We really want to not let conditions boil to that if we can help it. So talking about advanced care planning, talking about goals of care, helping assist people with medical decision-making, drawing on resources from caregivers are all ways that we try to avoid getting to a state of crisis, all the while seeing the caregiver and trying to help connect them or help keep them connected to whatever supports we can help them with. Many of you may be familiar with the Caregiver's Creed. If not, I suggest looking it up because I think it's a really handy reminder of a variety of things. And I'll just read it. Don't expect you to be able to see that. But again, looking it up online can be a handy resource. It says, I take care of myself. I know that if I am not healthy and sound, I cannot care for another person effectively. These are good reminders. I accept that caregiving involves an incredible range of emotions, from anger to joy, from resentment to compassion. I accept that my feelings are not right or wrong. They just are. And they are as natural and unavoidable as breathing. I ask for and accept help willingly. I involve my family, friends, and the community in the care of my loved one. I understand that it's not my role to do it all, nor is it best for my loved one for me to do it all. I actively seek out information that can help me as a caregiver. I recognize that information is empowering. I respect the preference and decisions of the person I'm caring for. I extend to my loved one the dignity and courtesy I would wish to receive if the tables were turned. I recognize that change, good or bad, is a natural part of caregiving. I remain flexible and open to change. I celebrate the small successes and allow myself to grieve the disappointments. I share my feelings with those who can empathize. And two more. I'm mindful of my own needs and I guard my rights as a caregiver. I do not allow my caregiver's role to overwhelm the other aspects of my life. That's a particularly tough one for sure. And lastly, I forgive myself my shortcomings and I congratulate myself for the effort and love I put into my caregiving. Certainly some much harder than others, easier said than done, but nonetheless, I think a powerful reminder to consider printing out or looking at online. It touches on so many important points in the multifaceted role of being a caregiver. And so from the perspective of just a neurologist, thinking about ways for caregivers to feel empowered, some practical ideas. I think one is remembering that you're human and it takes a village. Just this week, I was seeing a patient and his wife, and she said, I'm not sleeping well. The caregiver said this. And when I explored just a little bit, it was because she's ruminating about how she felt. She yelled at her husband inappropriately and got short-tempered with him. And she was kind of beating herself up for not being as patient as she would have liked to have been with him. And I couldn't make it better, but I did hear her and reminded her, I said, you're human and she's trying to do it all by herself. And connected her to social work, and hopefully that's helpful as a way to get them some help at home. But it really does take a village in terms of providing help, whether it's from other family members or paid help and so forth. I like to remind caregivers that their voice is equally as important in a patient visit, in a medical visit, right? We're often focused on the patient, the person with the diagnosis, asking them how they're doing and doing tests with them, motor tests and so on. But we really encourage the family members, whoever's with them, to speak up and provide their assessment of how things going and tell us how they're doing. So just as a reminder that caregivers' voice is equally as important. And if it's helpful, we try to help give caregivers permission to focus on self-care and not feel guilty. So common to see caregivers saying, well, I'm there all the time. I can't leave him or her alone. So that's just how it goes. And if we suggest, well, what do you do to go to your own doctor's appointments? Like, oh, I've been putting those off, because they feel guilty, sometimes about going and taking care of their own needs. And at least just saying, please, you need to do this. I want to give you permission to take care of your own needs. Sometimes that's helpful to hear, not always, but we offer that when we can. I think encouraging caregivers to stay connected. This, of course, is a self-selecting group. You're here, you're connecting, but there are plenty of people out in the community that are isolated, and trying to encourage them to stay connected, whether it's virtually for virtual caregiver support groups, by phone calls to their family or friends. We try to remind people to stay connected. It's easy to isolate sometimes, particularly in the throes of the pandemic a couple of years ago. I think seeking support groups can be helpful. It's not helpful for everyone. Some people leave support groups and feel worse. Some people feel better. It just depends. It's not one size fits all, but at least trying to help connect people with others who get it, I think, is really critical, because it's easy to feel very alone. Asking the medical team for help is always something to remind caregivers about, because often they don't think to do that. And that's part of what we're there for. We recognize that people living with HD aren't just the person with the diagnosis, but the family. Encouraging caregivers to write down their questions or concerns in advance of a medical visit seems obvious sometimes, but it's easy to forget. I think this is really helpful when you come to a visit to have an itemized list or some key points you want to discuss. And then consider seeking out a palliative care team if you think that would be helpful. A lot of people, again, haven't heard of it or don't know what it means or looks like. And hopefully this has demystified it a bit. So in summary, as I come to the last few slides, how can palliative care help in the face of Huntington's disease? Well, a care team can help strategize with you on how to bring more meaning back into life. Oftentimes that's the spiritual care team. We can provide assistance in medical decision-making, connections to community resources, extra support at home. Symptom management, we try to help with that as well, as I said. And then if we're along the journey, like that extra layer of support cloak idea, and we're meeting with patients and families periodically over years, that long-term relationship, I think, can be another source of stability for people and provide a sense of comfort in that way as well. And then lastly, and not leastly, helping with advanced care planning, documenting wishes, both for patients and their families. Is another way we could try to be helpful. So when you zoom out and think about the course of Huntington's disease, when does it make sense to have these kinds of conversations or involve a palliative care team? Well, DX is my abbreviation for diagnosis on the far left. At the time of diagnosis would be a great time to discuss goals of care. And I've discussed with you what goals of care means, to identify a medical decision maker and document it. And then moving forward in time, say point 2, on this timeline, we can provide spiritual support, help with any complex symptom management that isn't already being attended to, help with psychosocial needs, care coordination, connecting all the medical teams if we can. Moving forward again in time, maybe having a family meeting and preparing other family members for some what ifs of the future could be another way. Talking about prognosis. It's not an exact science, but we do the best we can when we're talking about if patients and families want to know how well and how long do I have to live. And talking perhaps about legacy work. Sometimes that can be helpful along this journey. Time point number 4, for example, could be additional family meetings, clarifying or documenting the advanced directive, maybe talking about hospice, demystifying that concept, saying, hey, did you know there's a medical team that if and when you get really sick can come to you and provide additional support, medications, et cetera, and really, introduce what hospice is and what it isn't, just as a source of education. And then further along the road, talk about, again, more symptoms, talk about care transitions. Sometimes the idea of whether or not to go into a facility or to bring in extra care at home can be, of course, a really hard or big decision. And talking through that or facilitating a family meeting could be another way that a team can be helpful. And then when someone is in the final stages of HD, the hospice team can be a big source of support. And this, of course, doesn't just apply to Huntington's disease, but when people are at a stage where we think they have 6 months or less to live, they become eligible for hospice care. And hospice is a medical team that comes to wherever the patient is, provides equipment, medications, 24-hour phone access. They become like a new 911. And again, that is anyone is eligible who has an illness where we expect a 6-month or less prognosis. And you should also know that hospice provides bereavement services for their families of patients who have passed away for 13 months afterwards, after they die. So that is a potential long trajectory of years of different time points where palliative care touches, remember it's high touch, not high tech, can be helpful. So my last slide, in summary, as you know now, palliative care is an approach to care and a medical specialty, often team-based, ideally team-based, focusing on quality of life for patients and their families, helping people live as well as possible, as long as possible, in the face of a serious illness at any stage. And spiritual care is often a part of that team, and they can further enhance support in Huntington's and other conditions. Don't forget about the homework, which I suggest would be identifying, if you haven't already, and documenting your medical power of attorney, as well as documenting your wishes. And that's all I have today. I really appreciate your attention. Any thoughts or questions at all? I am sure lunch is right there. Yes, so the question is, when somebody arrives at the emergency department and doesn't have in hand a medical power of attorney, or the hospital system doesn't have it on record, and they don't have family with them and they're unable to speak for themselves, is there a state registry of medical powers of attorney? If there is not, that's a great idea. In the face of an emergency, often the hospital has to provide emergency care and can't say, well, we're just going to wait until somebody shows up. So of course that's true. Like, we're not going to withhold appropriate care. But the default is always going to be try to extend or prolong someone's life unless they can show us documentation or speak to the fact that they have some limits in what they wouldn't want. So the best scenario that I suggest is that when people fill out medical powers of attorney, they make sure that their healthcare system that they're tapped into has that on file and it's up to date. And ideally, send that a picture on your cell phone or some electronic copy to your close family members so that they all have a copy of it electronically. Ideally, your medical power of attorney, the person you've designated, has a copy on their phone so that it can be shown very easily. But most important is to have it done and filed on file with your primary care or whatever your medical system is. That's such a great point. And what she said was that historically, you're a caregiver and a wife, or a wife and a caregiver. And historically, your husband who has HD was your person, your medical power of attorney and your go-to person. And as HD has regressed, he's no longer able to serve in that role. So even if you have done your medical power of attorney, documented it and filed it, things change. And so if that person is no longer the best for that role or able to consistently speak on your behalf and in your best interest, absolutely, it needs to be updated. And thankfully, again, you can easily update that without having to go through any big hoops to be with an attorney, etc.
It's always simple.
Thank you. Even bad days have good parts.
Even that is.
have their best parts. Thank you for that. Yeah, you know, I think we're all constantly learning and it's humbling because we don't have all the answers. I think something that I've recently learned is that I often go into these visits with patients and caregivers and ask caregivers, you know, how are you doing in a way that sets it up to make it feel like I'm expecting them to be doing poorly. And that just took me by surprise when I had this revelation, because there are plenty of caregivers that have victories, big and small, and find meaning in their role as a caregiver. And so I'm trying to do better and talk to others about thinking about how we ask these questions when we're checking in with caregivers, not just assuming things are terrible, but also just leaving it open to actually talk about, you know, what's going well. All right, thank you so much.
Thank you very much, Dr. Vaughn. Next, we're gonna have another familiar face that probably a lot of you recognize. We're gonna have Mr. Greg Jarvis come up and speak. I don't know about what, it's a surprise topic. But Greg's been part of the community for a long time and is very passionate. Thank you, Greg.
Hey, hello, everyone. Really short. Just want to mention a few things about our chapter. This event is put on by the Rocky Mountain chapter of HDSA. If you don't get our information, I'll put a sheet of paper back by our sign-in table so we can get your email address. Make sure that you get the monthly emails. We have support groups. We also have educational things throughout the year called Food for Thoughts, where you can join virtually. The support groups you can join virtually also. But we talk about topics this fall. We've been talking a lot about resilience that was brought up in this talk that Dr. Vaughn just did. But want to make sure that you're welcome to get that information. Both of these groups, that both the university as well as Dr. Kumar's office, the Rocky Mountain Movement Disorder Centers, are both centers of excellence. We're extremely fortunate to have two here in Colorado. The only other place that has two this close is in Chicago. And we also have one of the two that is a nonprofit, which is Dr. Kumar, which allows him to have a large number of research participants. But make sure to talk to the folks back at the research tables. We'll have awesome research going on. Some of the most highest number of participants globally or come here to Colorado to take part in those studies. So the more we have involved, the more we can continue to grow that effort here in Colorado. So thank you so much for attending.
Thank you so much again to all our speakers today, Dr. Kumar, Dr. Forbes, Dr. Vaughn, Megan, and Phyllis. Thank you for taking the time to come and speak with us on our Family Education Day. Thank you to the people who helped coordinate this event at the Rocky Mountain and University of Colorado Movement Disorder Centers, as well as the Movement Disorders Foundation. Thank you again to our lovely sponsors for making it happen. We've got Teva Pharmaceuticals, Rare Patient Voices, and Neuroprint Biosciences. Again, they will be here throughout the lunch period, so please go speak with them if you haven't had a chance to already.